Good morning, sir.
Good morning. Hi, good.
Meanwhile, if we load, yeah. So in the meanwhile, Parikshit, I would like you to load your, see at least it is visible on screen or not, that testing. You are, unmute yourself, Parikshit.
Yeah. If you can stop sharing your screen, can I just try for 1 minute?
Yeah,
because it doesn't let me share
yes.
while you're sharing.
So we are starting at 11 or?
No, we are starting. We were just waiting for 2 more minutes for other delegates to join. That's all. So now I think you are joined, so we'll start.
Dr. Velu is coming in at 10 or 11?
He
told me
Which
11.
session is next? So first session is infectious disease.
Okay.
So shall we start now, because then delegates will join later on.
Ma'am, yes, we can go around 31
Participants are already there.
Already joined.
So hello, good morning. Welcome back to day 2 of Hematology Update Vadodara. We had exciting session yesterday on day 1, 4. But today we have a different with special focusing on the deep vein thrombosis. And I'm glad to inform you all that we have overwhelming response to quiz last session, which is the last session of the today's meet. It is indeed great honor to welcome our distinguished faculty members, Lieutenant General Velu Nair, Dr. Abhay Bhave, Dr. Sukesh Nair, Dr. Vasant Nagwekar, Dr. Parikshit Prayag, Dr. Sanjeevan Sharma, Dr. Joseph John, Dr. Rahul Kamble, Dr. Sanket Mankad, and Dr. Hasmukh Balar. It is great pleasure to welcome quiz masters Dr. Amit Khurana and Dr. Arpan Mehta. I welcome all distinguished delegates to day 2 of Hematology Update Vadodara, and let us start today's panel discussion on gram-negative septicemia. Yes. So for gram-negative septicemia, our moderator is Dr. Parikshit Prayag, who has done his infectious disease specialization from Harvard University and from Stanford University, California, and he did his certified infectious disease course from the MD Anderson Cancer Unit, Houston, and from Stanford, he has done his specialization in the infectious diseases in transplantation. Currently, he is a consultant transplant infectious diseases in Dinanath Mangeshkar Hospital, Pune, and he is directed ID Fellowship, Dinanath Mangeshkar Hospital, Pune. He is visiting faculty at Attract Tata Memorial Center, Navi Mumbai. So over to you, Parikshit, for today's first session on infectious disease, and that is how I treat infectious gram-negative septicemia.
Yes. Thank you so much, Seema ma'am, and good morning, everyone. It's indeed a great pleasure because we are again back to this conference. I think last year it was all COVID which dominated the situation, but I remember I have fond memories from Baroda the year before last when I had actually traveled with Dr. Shashi Apte and Dr. Samir Melinkari for the hematology update. So it's really a conference that we had enjoyed. So and hopefully again we'll be back in person next year. So let us start the session. Let me introduce my fellow panelists. So we have Dr. Vasant Nagwekar, sir, who is a very well-known face in the world of infectious diseases in India. Someone whom I look up to, and someone with whom I have worked quite a bit, not formally, but in the form of, book chapters and meetings and so on. So Dr. Nagwekar is a senior consultant in infectious diseases at the Lilavati Hospital and at the Global Hospital in Mumbai. And he has a special interest in transplant infections as well. We also have Dr. Sanket Mankar, who has been trained at CMC Vellore and who is currently an infectious disease consultant at the Talbi Hospitals in Ahmedabad. And then we have Dr. Hasmukh Balar, who is a hematologist and a BMT physician at the Surat Haematology Centre in Surat. He hails from Baroda, but he's trained right here in Pune at the Sahyadri hospitals. And then we have Dr. Rahul Kamble, who is the consultant microbiologist and also the chief infection control officer at the Lilavati Hospital in Mumbai. So it's indeed my great pleasure and honor to welcome all of you. So let me just start sharing my screen. Okay, so for the next 45 minutes or so, through a case, we are going to see how do we manage or the certain aspects of managing gram-negative infections in hematology patients. So this is a vast topic and, one about which we could talk for days. So we are going to highlight some of the important aspects. And, as I go along at every step, I'm going to invite comments from my fellow panelists. So let me start off with the case. So we have a 40-year-old gentleman with AML who is post his 7+3 induction therapy and now has febrile neutropenia. So again, he is someone who is presenting with AML. So he has qualitative neutropenia. Now for 5 days, he has quantitative neutropenia and he has just received his 7+3 induction chemotherapy. So now he has febrile neutropenia without any localizing signs or symptoms, something that we see very often in our clinical practice. So let me start off with Dr. Balar, and I'll come to my ID colleagues and micro colleagues a little bit later in the presentation. So Dr. Balar, in your practice, before you involve any of us, what do you start this patient on? Someone with febrile neutropenia, now he has had neutropenia for 5 days, quantitative, but we all know that, he's qualitatively neutropenic with AML. No signs and symptoms. So what workup would you send on day 1 and what would you start him on?
Thank you, Dr. Parikshit, for your kind introduction. And particular this case, I will send the baseline investigation like blood culture, 2 set of blood culture, include another like CRP and procalcitonin. And meanwhile, we'll start with the piperacillin tazobactam combination, single drug antibody monotherapy.
Right. Fair enough. So, choice of empiric therapy for febrile neutropenia should include anti-pseudomonal coverage, and then the choice of antimicrobial really depends on the local patterns that you have in the hospital. You have to take into account, your incidence of ESBL infections, what kind of susceptibility patterns you see for your gram negatives, what is your pseudomonas susceptibility, which are your big gram negative bugs. So he was started on piperacillin tazobactam as Dr. Balar mentioned. And 2 days later, he remained febrile. So the hematology team changed him to meropenem, and his procalcitonin at that time was 22. His blood cultures were repeated, and 2 days later, he remained febrile. So now he has been on meropenem for about 3 days. He's been febrile. He's still neutropenic, and his procalcitonin is now going up from 22 to 40. And the lab calls you and says that they have just detected that a gram-negative bacteria is growing in his blood cultures. So let me start off with my ID colleague. I'll come to Nagwekar sir a little later. So let me start off with Dr. Sanket. Sanket, at this point of time, what are the kind of changes that you would like to make? Febrile neutropenia, procalcitonin is increasing. He has been on meropenem for 3 days. He remains febrile, and while on meropenem, he is growing a gram-negative.
See, the most important thing here would be to see the local prevalence of the CRE that is there in that particular neutropenic setup. If they have a high incidence of CRE Enterobacteriaceae, definitely in that situation, I would like to ask the microbiologist first, personally, whether it's growing a lactose fermenter or a non-lactose fermenter. My obvious choice in this case would be, I think, continuing meropenem and adding colistin in this particular scenario. One more thing that I would like to ask the hematologist also would be, what is his expected duration of neutropenia in this particular patient? Whether it is going to be more than 7 days or not, number one, right? And secondly, whether the patient has a central line or a port inside too. right? So these are the certain basic things that I would like to ask the hematologist.
Yes, thank you. Nagavekar sir, your comments on, the kind of empiric changes that you would make, knowing that he's growing a GNB on meropenem and his procalcitonin is going up. Would you go the polymyxin way or would you go the BLBLI way?
So the first thing is, the first thing will be, I think I'll have to go back to the history of this patient, how many hospitalization he had before he came in for induction chemotherapy. Because if he has got multiple hospitalizations in the past, like, for his PU or whatever, then possibly what I would have done is I would have sent his rectal swab for if he had multiple hospitalization. If he's coming for the first time, then the question doesn't arise, and that is a practice to follow. If you had hospitalization in the past, I would send a rectal swab for to just as a surveillance, not to treat that. That is one thing. And second thing is, after knowing that is growing GNB in the blood, the most important question would be to answer is from where is this GNB coming? So whether it is does he have any lines, or whether he has got any rectal. A patient may not complain of rectal tenderness, so I would go ahead and examine his rectal area to look for that. Or whether he's most likely induction chemotherapy means he would be on cyclophosphamide and all that. So I think there would be exfoliation of the GI tract. So most likely this would be translocation from the gut, provided he doesn't have any central lines or port or anything which has been put for the treatment. So second thing is, from where is this bug coming? And third is, if I have this GNB, yes, I would go with a colistin or whatever polymyxin based therapy. But I would go with a colistin based therapy because it could be a urinary tract also. So till I'm not very sure, I would go with a colistin as a main therapy. And then possibly I would add either high dose meropenem or fosfomycin, because fosfomycin, the reason is, fosfomycin more than 95 to 98% covers the E. coli, and Klebsiella, to the extent varying from hospital to hospital, it would cover from anywhere from 40 to 60, 65%. So I think better than Mero would be to add phosphomycin till I get my isolate identified. Another thing what I would do is, since I've got a GNB and I've got access to BCID panel, I will quickly subject this GNB to a BCID panel, which I'll get an answer within 2 hours. But till I get an answer, I wouldn't wait. I would definitely pump him with colistin loading dose, and maybe 2 gram 8-hourly meropenem, or it could be fosfomycin, because the most likely it will be translocation from the gut. I wouldn't expect neutropenic enterocolitis and to develop so soon on 7+3. It is much later on. So this is how would I look at this patient. I would go with a colistin maximum.
Yes, thank you so much, sir. So, I absolutely agree. As Nagavekar sir mentioned, it is very important when we have a GNB growing to optimize all our diagnostics. And that is where I'm going to get Dr. Rahul in the picture now. So when we have a GNB growing in the blood cultures, the first thing that we would want to know is that what kind of GNB is it? Is it a lactose fermenter? Is it an enterobacteriaceae? What is it? What is the kind of bug that is growing? And yes.
Yeah, so I just wanted to, among the different, you have written change to ceftazidime avibactam or ceftazidime avibactam plus astronem. I think to the audience, I want to say that when you do not know what is the gram-negative bacteria, you have to hit it with the most broad antibiotic, which would cover almost all the gram-negatives. And the common gram-negative would be E. coli, Klebsiella, Pseudomonas, and Acinetobacter. But here we are not looking at Acinetobacter, we are looking more at E. coli, Klebsiella, maybe Pseudomonas, but I'll tell you, in my clinical practice in India, we hardly see Pseudomonas. Though Pseudomonas is the most likely pathogen in the Haemato Onco or AML induction chemotherapy, whatever. Another thing is, I want to tell the audience is this ceftazidime avibactam plus astronem looks very fancy, but it's a very, very narrow spectrum drug which would cover only your Enterobacteriaceae group. So, it's a very narrow drug. So we should not get fascinated with the new drug which has come into the market, that it would cover everything. It's a very narrow spectrum drug. Never use it until unless you have a sensitivity or susceptibility shown to that of pathogen. So that's why colistin. Thanks, Parikshit. Sorry.
Yes. No. I was actually exactly coming to that. If you talk about option F, which is ceftazidime avibactam plus astronem, as sir mentioned, although our chances of having a Klebsiella in this setting and then E. coli would be far higher than something like Pseudomonas and Acinetobacter would be lower on the differentials, I would still not advise anyone to start this as empiric therapy, because there are certain bugs which can escape this type of a combination. As sir mentioned, for the Enterobacteriaceae, which means that if you have a Klebsiella or an E. coli or an Enterobacter, Citrobacter, Serratia, and so on, this can be a good combination because so avibactam itself covers most of the clinically important enzymes that you get, which are non-group B enzymes. So except for the class B enzymes, it will cover most of the clinically important Enterobacteriaceae enzymes. So when we have CTXMs, which are ESBLs, or KPCs, which we don't see a lot of, and OXA48, of course, which we see a lot of in clinical practice. And then Astunam would be unaffected by the class B enzymes, which would normally have been destroyed by ESBLs like CTXMs, or certain OXA48 variants will also destroy Astunam. So when we talk about these things, ceftazidime avibactam plus Astunam is a pretty narrow spectrum antibiotic. For Enterobacteriaceae, it's a great choice. For Pseudomonas, it could be a hit or a miss because Pseudomonas can have many non-enzymatic mechanisms of resistance. For example, efflux pumps. It can also produce some enzymes like, the PER or the webs, certain OXAs, which would be difficult to destroy with avibactam. And for Acinetobacter, this is going to be a poor choice because our Acinetobacters the Acinetobacter landscape is all dominated by class D enzymes and class B enzymes. So the OXAs of Acinetobacter are not well destroyed by avibactam. And also the class B enzymes are not at all well destroyed by avibactam. Plus Astunam is a poor anti-Acinetobacter agent. So as we've been mentioning, empiric use of ceftazidime avibactam plus Astunam should be avoided. Once we have a clearer picture as to, what is the bug, what are the kind of enzymes that it is producing, what are the resistance mechanisms, only then can we go over to definitive therapy. Till then, of course, with the clinical picture of failing meropenem, I would probably also go with something like colistin plus fosfomycin, and make sure that this patient is not having a urinary infection. So if I go for something like colistin plus fosfomycin, I have good chances of covering E. coli and Klebsiella. Pseudomonas, again, fosfomycin itself is not a great anti-pseudomonal agent. And Acinetobacter, again, is not good. For Acinetobacter, basically, I'm using monotherapy here with colistin. But, for Acinetobacter, which is carbapenem resistant, initially upfront, if the patient is not that sick, monotherapy is not a bad idea. In fact, the evidence for combination therapy is not that strong. So once you have more definitive information, of course, you're going to tweak this regimen. But as an empiric regimen, probably colistin plus fosfomycin would be a good regimen to upgrade this patient to. Again, if you look at colistin plus meropenem, then a lot of our carbapenem resistant bugs in India actually have very high MICs. So again, unsure of what meropenem will add to this combination. So I would agree with Nagvekar sir. I would definitely optimize all the diagnostics upfront, try and get the something like a BCID panel or a sepsis flow, which is a PCR test that we do in-house here in our center in Pune, and try and optimize all the diagnostics to come up with a combination regimen. So I'm going to come to the enzymes a little bit later, but this is what the cultures finally showed. So it basically, the culture showed a Klebsiella, which is, as you can see here, resistant to even the 4th generation cephalosporins. It is also resistant to carbapenems. And colistin, as we have now started calling it, it is colistin intermediate. But we have to take this with a pinch of salt. This is the Vitek colistin, which is showing as intermediate. And it shows resistant to ceftazidime avibactam as well as resistant to Astunam. So here, we are going to focus on this question. What are the likely enzymes which are involved in this picture? So Dr. Kamble, let me get you into the discussion. What are the kind of enzymes, not just for this organism, but what are the kind of enzymes that we commonly see with Klebsiella? And, we are going to talk about this as well. What are we doing to detect these enzymes?
The method that we use for the detection of the carbapenem resistance enzymes in our setup is the SOHOT gene expert SOHOT carbapenem resistant detection test. And in our observation, we have seen that in the Enterobacterial cells, 1/3 of our isolates are OXA48 producers, 1/3 are NDM producers, and 1/3 are OXA48 plus NDM producers, and few are KPC producers. That was about genotypic detection. At times we do phenotypic detection of the carbapenem resistance enzymes also. So most commonly is the OXA48 and NDM.
Right. Thank you. So, I'm going to come back to our patient a little later. So, these are the methods, as Nagvekar sir was mentioning, it is important to get all this information upfront when I'm trying to decide what sort of organism I'm treating and what is the resistance pattern that I'm dealing with. So in clinical practice, we have a few ways of detecting these enzymes. So we have this simple CARBA-R test, which is done on the GeneXpert platform, and in fact, Cepheid is now coming up with a quick bedside panel, something which would look like a pregnancy test or a COVID antigen test, which would give us a quick idea of the kind of enzymes that are involved. So the CARBA-R test is a good, simple, robust test. The reason is that it detects the 5 clinically important enzymes in clinical practice. KPC, as we have been saying, it's not very common in India, but it's the class A carbapenemase of Enterobacteriaceae, and sometimes even Pseudomonas and Acinetobacter. It detects the important class B enzymes, so the New Delhi metallobeta-lactamase, the Verona enzymes, as well as the IMP. These are all important class B enzymes that the CARBA detects, and then OXA48. So basically, with this type of a picture, when I run a CARBA-R test, of course, that would be after I have the isolate. But when I run this CARBA-R test, I am basically able to decide whether to give this patient something like ceftazidime avibactam alone or to combine it with Astonam. Then ESIM and the MSIM tests that I mentioned in the previous slide, these are good, simple, robust tests. Again, they answer 2 questions. Is a carbapenemase present? And if it is present, is it a metallobeta-lactamase? Then this is something that we use in-house. This is a European PCR panel. I initially started this from a research grant, but then we have been doing it commercially. So this is able to identify almost 20 different enzymes. The advantage here is that we are able to identify the OXA23, OXA24, as well as the OXA51, which are usually Acinetobacter enzymes. And OXA51 we have seen usually is not associated with carbapenem resistance unless it has a ISP or a promoter region. So again, the long story short here is that there are different ways of identifying these enzymes, and we have to get help for our hematology colleagues who have joined in the audience. You have to get this sort of information from your microbiology department upfront. So when we ran this test on this particular patient, even before we had the blood cultures, this is almost 48 to 72 hours before we have the blood cultures, we have the organism detected as Klebsiella. As Nagvekar sir was saying, that would be the most common organism associated with this type of a picture, especially a neutropenic patient with GI translocation. In our setting, it would have to be Klebsiella and E. coli more than Pseudomonas and Acinetobacter, because he wasn't really showing any signs of line-related infection or pneumonia. So this patient turned out to have Klebsiella pneumonia, and when we did the PCR sepsis flow panel, it showed SHV, CTXM, NDM, and OXA48. So again, this type of picture is commonly seen with our Klebsiellas. In fact, almost 80% of our Klebsiellas have been multiple enzyme producers. So if you go through these enzymes, SHV can be an ESBL, especially later generation SHVs like, 2Es, they can be ESBLs. CTXM is most commonly an ESBL, or it's also the most common ESBL seen in India. And again, NDM is the common group B enzyme that we associate with Klebsiella here. And OXA48 again, which we see a lot of, as Dr. Kamble mentioned, we see a lot of OXA48 with Klebsiella. So if you study this enzyme pattern, then almost 48 hours before you get the actual susceptibility results, you know that it is going to be carbapenem resistant. So if I use something like avibactam, it is going to destroy SHV, CTXM, and OXA48 with a fair certainty. Of course, we have started having OXA48 mutants now, but again, it's rare at this point of time. And with Klebsiella, I am not too concerned, although this is all relative, but I'm not too concerned about, production of efflux pumps or mutated PBPs. So I'm reasonably sure that, this avibactam will be able to destroy my SHV, CTXM, and OXA48. What remains is the class B enzyme, which is an NDM. And if I add Astonam into the picture, then Astonam will be unaffected by my class B enzyme. So which means that, again, long story short, if I have access to, a robust microbiology department, if I have Dr. Kamble in-house, I'll quickly dial him up and ask him for this sort of enzymatic information, and then base my therapy on these enzymatic results. Nagvekar sir talked about the biofire panel, and I agree, we have to be able to detect these enzymes before we actually have the phenotypic resistance pattern. And this is what a BCID2 panel looks like. Again, it gives you the 5 enzymes of the CARBA-R test. Importantly, it also gives you CTXM, because CTXM is important in this picture, because it is an ESBL which can destroy Astonam. So when I am, making decisions about combination therapy, I would want that information. it tells me MCR1 mediated colistin resistance, which I again take it with a pinch of salt, because MCR1 mediated resistance may not be the main colistin resistance mechanism in the country. There is certain amount of inherent resistance to colistin in bugs like Proteus, Providentia, Morganella. That's because they are able to increase the positive charge of the lipopolysaccharides. Then you have got MGRB and MCR1 mediated resistance, which again is going to add positive charge to the lipopolysaccharides, because colistin is a positively charged compound. So the bacteria makes every attempt to increase its own LPS positivity in order to repel colistin. And then you also have certain efflux pumps associated with colistin resistance. So again, MCR1 may just be the tip of the colistin resistance iceberg and not a very common mechanism of resistance, especially in South Asia, Eastern Europe, Western Asia, but something which if I find will be useful. So again, this panel can be expensive, but when we talk of expensive, we have to also take into account what is the kind of therapeutic decisions it's going to bring along with it. So a 15,000 panel, if it's going to save you, maybe 10,000 per day of antibiotics, then it also makes financial sense. So cost of therapy is something which has to be considered holistically and not just the cost of that particular test. So this is the kind of patterns that we see in at least our clinical setup. So with E. coli, we see more of NDMs than OXA48. Dr. Kamble mentioned that, with Klebsiella, we see OXA48 and NDM, and in almost 30-40% of the isolates, as he mentioned, we see a dual carbapenemase picture. With Pseudomonas, we see more of class B enzymes, and again with Acinato, we see more of class D, like 23, 24. 51 in my experience really hasn't been carbapenem resistant, which we also see 58. Now, very interestingly, the colistin resistance associated with carbapenem resistant bugs can be different. So I think we have talked about this. So coming back to our patient, so let's say, if I actually did run the MICs on this patient, so we have two options now. So the initial culture report, which looked like, ceftazidime avibactam was resistant, Astonam was resistant, colistin was intermediate. Now I ask my microbiologist to do a few things for me. One is that, run colistin MICs by broth microdilution method or by the drug elution method. And I also ask him to do ceftazidime avibactam plus Astonam synergy. I ask him to do enzymatic testing, and I also ask him to give me MICs of some of the other agents, because I'm going to require this sort of information when I'm trying to choose my combination therapy for this patient. So look at how different the culture report looks now. So as I was mentioning, if I had to pick something with colistin, this meropenem MIC here is very high for me. So look at fosfomycin or tigecycline. Now, if I look at the actual MICs, then for tigecycline or fosfomycin, they are not very far away from the breakpoint. So in this type of a scenario, tigecycline or fosfomycin combination with a polymyxin or a colistin backbone is actually more useful than a meropenem based combination therapy, because as the MICs go above 16 or definitely above 32, meropenem doesn't add much to your combination therapy. Of course, this is a blood isolate, so tigecycline will not have very high concentrations in the blood. It's an antimicrobial that gets very quickly deposited into the tissues. So an hour later, I have only 1% of the drug as free drug in the blood. So based on this combination, I have two options here. Basically, a polymyxin backbone. So a polymyxin B or a polymyxin E. As Nagwekar sir mentioned, if it's a urinary isolate, I'll go with colistin. For non-urinary isolates, I'll go with polymyxin. If I am not using Zavicefta-Astonam combination, then I would probably add fosfomycin as my agent of combination therapy. So these are the kind of things that we need to consider before we choose combination therapies for this patient. So again, this was the enzymatic pattern. So now let's turn our attention to colistin by broth microdilution. So initially, when the Whitek report was released, it gave me an MIC which showed it to be intermediate. Now we have abolished the term colistin sensitive. We either call it colistin intermediate or colistin resistant. Now, if you compare Whitek with broth microdilution, there can be discrepancies, which means that if the Whitek gives you a colistin MIC which is less than 2, so which is intermediate, it can actually be resistant. Usually when the Whitek gives you it as resistant, it is not wrong, which means that the Whitek can sometimes underestimate the colistin MICs or underestimate the colistin resistance. So let's get Dr. Kamble back into the picture now. Broth microdilution is challenging for colistin. So doing broth microdilution is challenging There are commercial panels, but they are not very well approved at this point of time. It's a difficult test to run because, technically it's difficult. Colistin is a compound which can stick to the kind of materials that we use for running these panels. So Dr. Kamble, tell me your experience about colistin MIC testing in your institute, and, what is the take home message for our audience, as far as colistin MICs are concerned, and how to go about this?
We do a selective reporting of colistin, and that too by broad micro dilution. So we don't report it by the automated methods like Vitek or Phoenix. And it's been it's agreed. It's a broad micro dilution gives the correct MICs as compared to the Vitek or Phoenix.
Right, absolutely. So whenever we look at colistin MICs, we have to take it with a pinch of salt. We have to talk with our microbiology department. So as he mentioned, either broad micro dilution or using drug elutions. There was a very good paper presented in ID Week last year. The drug elution is also now having considerable evidence as the testing method for colistin MIC. So in our center, we actually do the drug elution. So you can see here that, with this, for this particular patient, when we did the drug elution, this MIC actually turned out to be more than 4. So colistin here is actually resistant. So let me go back to Nagvekar sir now. So sir, now for this patient, we have confirmed by synergy testing that Zavicefta Astonam can work because we have SHV, OXA48, CTXM, and NDM. So as we can see here, the Zavicefta tube has growth, the Astonam tube has growth, but when we combine it for the susceptibility testing, we are seeing that the isolated, so the test tube is fairly transparent. So which means that the synergy test is positive. So at this point of time, we have two options, either to go with colistin plus fosfomycin, as you mentioned, or to go with Zavicefta plus Astonam. So what would be your choice, and how would you go about as far as further therapy is concerned?
If the patient is hemodynamically stable, I think Astonam would be a fairly decent combination for this patient, especially looking at translocation from the gut most likely, and bacteremia. So there are papers which talk about ceftazidime avibactam versus colistin, and they found the mortality to be slightly lower with ceftazidime avibactam. They are not compared with Astonam. With ceftazidime, mainly from the colistin nephrotoxicity and the morbidity point of view. So I think I would preserve my polymyxin, polymyxin based therapy here, and I would go ahead with ceftazidime avibactam Astonam, keeping a close watch on the patient.
Yes, thank you, sir. So, at this point of time, as I mentioned, we have two, basically we have two, I wouldn't say good, but decent options for this. Zavicefta plus Astonam, or, using polymyxin-based therapy. One thing is that, we have been doing ceftazidime avibactam plus Astonam synergy testing, and we have had 4 cases in the last 6 months, wherein, with this type of enzymatic picture, also the synergy test has been negative, which means that we have to ask ourselves, a number of questions. One is that, are there certain mutations in the OXA48 that we are seeing, because these weren't cases that involved the KPC. So KPC mutations have been described, in the US, especially from Detroit, that which would render it resistant to avibactam. But are there OXA48 mutations that are now cropping up? The second question is that, sometimes the pharmacokinetics is a little difficult to match in these patients, especially when they have renal impairment as far as the dosing of Zavicefta and dosing of Astonam is concerned. Or are there NDMs which would, especially NDM 1 and 2, there are certain variants. Again, there are almost 20 different NDMs described. So can my Astonam work against every isolate which is producing NDM? So these are important questions to ask. And then again, with E. coli, we can have associated PBP mutations. So again, Zavicefta Astonam can rarely fail in this type of setting. So ideally, we would like to confirm it with synergy testing. So let's say, so we have these two options. So let us try and compare these options, and let us try and see, what we need to do. So we already answered the question, what do we need to do for colistin or polymyxin-based therapy? As Dr. Kamble rightly mentioned, we will have to make sure that the colistin actually has decent MICs and not really go by the kind of susceptibility patterns given by the Vitek machine. Now, this leads us to the next question. So if we are planning to use colistin-based therapy, let us say we run the broth microdilution test, confirm that the MIC is less than 2. Then the next question is, do we really need? So we have decided we are not going to go for Zavicefta Astonam, maybe because of finances, maybe because of availability, maybe because I don't have access to enzymatic testing in my setup. So I'm going to go for the safer and the time-tested option of polymyxin backbone. So now I have also confirmed that polymyxin MICs are less than 2 by broth microdilution. Dr. Sanket, at this point of time, would you like to go for polymyxin-based monotherapy, or would you like to go for combination therapy at this point of time?
I just wanted to know whether this is a peripheral blood culture that was positive, or was it a central line that was positive?
Both were positive with no differential in the
TTP was not significant. Okay.
Yes.
Okay, so it was not a CLABSI essentially, technically speaking. Okay, so that is out, and this patient is hemodynamically stable, I believe.
Yes.
With no localization clinically.
No. So clinically, it looks like a GI translocation.
Okay, and we have decided that Cas-IV plus Estunam currently is not in our bucket financially or due to some other constraints.
Yes, I mean, I'm just saying it for the sake of discussion. Actually, we gave XVth Haematology, but for the sake of discussion, let's keep that out and focus on polymyxin.
So if we are going to use polymyxins, that we need to use the combination therapy, right? That is mainly because I think colistin might suffer from heteroresistance patterns also. So if I'm going to use colistin, then I need to cover it up with another backbone in order to prevent rising MICs to colistin and prevent therapeutic failure in this case.
Okay, fair enough. So, if you look at the evidence for combination therapy, the evidence is a little stronger for Enterobacteriaceae. It is decent for Pseudomonas, and it is not that robust for Haematology. In fact, when they were coming up with a 25-member committee of global experts for guidelines, then the experts actually voted 13-12 in favor of combination therapy for Acinetobacter. So that's how divided it is. But, having said that, we have a lot of other constraints with polymyxins that I will come to. So again, combination therapy would probably be the way to go about it as far as, Klebsiella or E. coli or Enterobacteriaceae are concerned. Personally, in my clinical practice, I usually prefer combination therapy for GNBs, which are carbapenem resistant. Now, once we have decided that we are going to use polymyxin-based therapy, we have decided that we are going to use combination therapy. Now, we come back to the question that should it always be polymyxin plus meropenem? And the answer is no. We have touched upon this, but the answer really depends on a lot of factors. Where do I want my drug to act? What is the MIC that I'm seeing? How far away is my MIC from the break point? Which is the bug? What are the different resistance mechanisms that I'm trying to cover? Am I trying to cover for PBP-mediated mechanisms of resistance? So all these factors go into deciding the combination therapy. So very important take-home message is that the automatic answer for this patient is not polymyxin plus meropenem.
Intervene, Parikshit. There was go just one slide before that sensitivity pattern. Yeah, no sensitivity. Yeah, here it is showing the chloramphenicol sensitive. So I just wanted to ask from you, have you ever used chloramphenicol if patient is not affording and you want to, cover it with a broad spectrum, and how is your experience chloramphenicol now? We have used it before, and after the evidence of post-chloramphenicol pancytopenia or aplastic, it was gone drug. But now again, it has come back. So what is your opinion on that?
Right. So ma'am, as you rightly mentioned, chloramphenicol is a drug that has revived itself in the carbapenem resistant era. However, monotherapy with chloramphenicol, especially for carbapenem resistant isolates, is not supported by a lot of literature. So it's like using minocycline monotherapy for Acinetobacter. So personally, I don't use monotherapy with chloramphenicol for these type of patients, neutropenic sepsis or neutropenic fever with carbapenem resistant Klebsiella. So not an option that I would recommend, because we don't have a lot of literature for monotherapy at this point of time. And again, of the toxicities, hepatotoxicity, bone marrow toxicity that you mentioned. So, going ahead, what Nagwekar sir was talking about, at this point of time, if you had to compare polymyxin-based therapies versus BLBLI therapies or other therapies, there is some data which is starting to emerge that the non-polymyxin-based therapies might actually be a little better. Of course, as he mentioned, this is dominated by the Western landscape, which is devoid of NDM. So these are mainly studies comparing BLBLIs without Astonam, because they don't have a lot of group B carbapenemesis in the Western world. So this data mainly includes KPCs, especially the Greek study which compared colistin with ceftazidime avibactam, the fourth one on the list here, which said that the mortality with colistin was 33% versus 8% with ceftazidime avibactam. So the isolates here were mainly KPC isolates, but there are studies and there is data starting to emerge that non-polymyxin based therapy might actually be slightly better at this point of time, but provided we have all this information, so not upfront or not empirically. Once I know what my bug is, once I know what kind of enzymes it is producing, once I have all the clear picture, and these are some of the reasons for it. One of the most important reasons is that the pharmacodynamic targets are difficult to achieve with polymyxins. So for example, if I had to roughly quote, if I don't of course have access to drug levels in my clinical practice, but let's say I'm using something like colistin or polymyxin, and I achieve drug levels of 2, I'm roughly achieving an area under the curve of around 50. Now, if I divide this by the MIC, let's say I have an isolate with an MIC of 2, then 50 divided by 2 is 25. So I'm roughly achieving, if I have good drug levels, for an isolate of MIC 2, I am achieving an AUC MIC ratio of around 25. The constraint with this is that I don't have access to drug levels in my clinical practice. Most of the times, even with BMT, I don't really get accurate MICs. I get it as between 1 and 2, or less than 1, less than 2, or more than 2. And the other part is that what are good AUC MIC ratios? So for pulmonary infections, AUC MIC ratios for even achieving 1 log kill, which means that to reduce the burden of organisms tenfold, good AUC MIC ratios are even more than 100. So these are the kind of AUC MIC ratios which are actually needed. So what will happen if I really increase my drug levels? I would enter into the zone of toxicity, because polymyxins are compounds which have a very narrow therapeutic safety index, or there are toxicodynamic concerns. So again, to summarize, we are not getting accurate MICs. We are definitely not getting drug levels in our clinical practice. So I really don't know whether I'm optimizing the pharmacodynamic targets. And that is why, as Nagwekar sir rightly mentioned, we have emerging data that the non-polymyxin based therapies are coming again into focus at this point of time. Dr. Sanket, polymyxin B versus colistin, when would you choose polymyxin versus when would you choose colistin?
Technically speaking, I think polymyxin B is relatively a safer drug as compared to that of colistin in terms of nephrotoxicity. The only thing that matters with polymyxin B is the neurotoxicity component. The paresthesias that occur with polymyxin B are seen in clinical practice. So I think polymyxin B in the dose of 7.5 lakhs BD, I think I would prefer it more. But technically speaking, in my practice, what I have observed is that polymyxin B is an ID physician's drug and colistin is more of an intensivist drug, right? I think the ID specialists tend to prefer polymyxin B. That is mainly because of it's got a better toxicity margin. One thing is, and it is relatively less nephrotoxic, can be given unchanged even in patients who are on hemodialysis also. So a lot of advantages with polymyxin B. So I think I definitely would opt for polymyxin B rather than colistin.
Yes, thank you.
If neurotoxicity occurs in such patients who are
I was coming to that now. I was coming to that. Nagwekar sir, there is fair amount of data for nephrotoxicity, but what is your experience with the comparative neurotoxicity for polymyxin and B and colistin? Nagwekar sir?
Okay, so I've seen nephrotoxicity definitely much more with colistin, but the neurotoxicity I've seen with polymyxin B to be much higher. In fact, I've seen a couple of patients one patient we lost in the ward who did complain of paresthesia, next day morning was dead. So I think sudden respiratory, most likely it must have been sudden respiratory arrest which must have occurred. And we had a possible another respiratory arrest in ICU, and that also I think. So polymyxin B is known to cause acute respiratory arrest, just like a myasthenia gravis, because I think that is what you have to be worried about when you're giving polymyxin B therapy. And also, even if it doesn't cause in the beginning, cumulative toxicity can be a possibility in this. So I think when you're giving polymyxin B, you have to be very watchful. Colistin I'm much more comfortable, but I think it's individual based. There are many consultants who are more comfortable with polymyxin B. I'm more comfortable with colistin, knowing that colistin has a variability with different hosts can be variable. I'm aware of that. whereas polymyxin B has a much smoother linear graph with no fluctuations in the concentrations, as well as no host different hosts having a similar levels. But somewhat, I'm more comfortable with colistin. Maybe I may not be correct, but this is how I go. But whenever I'm using polymyxin B, I'm more worried about the neurotoxicity part in that.
Right.
And it doesn't work in your urology or neuro, both the places it will not work. And you also, sometimes I think joints also, I think colistin is better than polymyxin.
So, sorry, if someone does develop neurotoxicity or early signs of neurotoxicity on polymyxin B, what would your approach be? Change to colistin or abandon the class altogether?
So, if the patient has developed a neurotoxicity in the form of ataxia, okay, so so sometimes if you give loading, no, I mean, if it goes the say 4.5 BD you are giving, if you give it very rapidly, the ataxia, cerebral ataxia or instability and all that can be much more. So maybe you can try giving it over 4 to 4 hours or something, 3 to 4 hours. That might reduce the that neurotoxicity. But if it's a respiratory paralysis, okay, I think I'll have to look for an alternative, completely alternative treatment, and possibly with, as you said, newer emerging. If it's a Acinetobacter or Pseudomonas, then possibly I would look for something like cefiderocol or something which is not available in India. That is what I would. I think we are waiting for that molecule to come to India, and then. So yes, but the experience with colistin causing or polymyxin B causing neurotoxicity, severe ataxia, and then continuing and all the other part has not been great from my side. But yes, the alternative is to give slowly infusion over 4 hours. That might help. But if it's a respiratory, then there is no question of either or using.
Absolutely. Thank you so much for that. So this was about Enterobacteriaceae. In general, for the to just wrap things up and for the final 2 or 3 slides, if we are treating carbapenem resistant Acinetobacter, as we've been mentioning, ceftazidime avibactam plus aztreonam can be a poor choice because avibactam is not able to destroy a lot of the clinically important Acinetobacter enzymes. If you look at Acineto ESBLs like PER or Webs, if you look at Acineto carbapenemases like OXAs, OXA 23, 24, and of course the class B enzymes, avibactam is not able to destroy any of these enzymes. Plus, aztreonam in itself is a poor anti-Acinetobacter agent. So this, as we have been mentioning all along, so this makes it a poor choice for empiric therapy. So it is recommended to use BLIs only once we have all the microbiological information. So which is the bug, what are the enzymes, what are the resistance mechanisms, and so on. So usually, for carbapenem resistant Acinetobacter, polymyxin based therapy still remains the backbone. Is combination therapy always required with polymyxin? That is a little bit controversial, or it's in the gray zone. However, looking at the recent data and looking at now the kind of information we have about the pharmacodynamic concerns with polymyxin and also the lack of accurate MIC testing across the country, it would still be safer to go for a combination-based therapy with polymyxins for Acinetobacter. So again, there are certain other agents that we have to keep in mind when we are dealing with Acinetobacter. So something like sulbactam, combination therapy, including rifampicin, minocycline, tigecycline. So minocycline, tigecycline are good options. Again, resistance to one may not predict resistance to the other because there are different efflux pumps which are involved for resistance against tigecycline and minocycline. So even if TG is resistant, it's still worthwhile looking for or testing for minocycline as far as Acinetobacter is concerned. It also has good inherent activity against Acinetobacter. The same thing holds true for sulbactam, good inherent activity. One thing would be to compare something like ampicillin MICs and then or the zone of ampicillin versus comparing the zone of ampicillin sulbactam and for the same isolate and trying to see if sulbactam is going to add something to your treatment regimen. So if I have a patient who is on a polymyxin based therapy, develops neurotoxicity, as Nagwekar sir mentioned, develops serious neurotoxicity. So if there are concerns of respiratory depression, then it's a tricky situation. But maybe something like a combination therapy including minocycline plus sulbactam or high dose minocycline depending on the MICs or mero-mino-sulbactam. These are some of the options that I can have for Acinetobacter. For my Pseudomonas, again, it is ceftazidime avibactam plus aztreonam or definitely more chances of working compared to Acinetobacter, but not 100%. because there are efflux pumps, there are other types of resistance mechanisms involved here. There are PBP mutations. So, and again, for Astronom, Pseudomonas can be an AMP-C producer. So again, there are concerns for this. Once we have cefderichol, it might be a better agent for Haematology for sure, and even for Pseudomonas. At this point of time, if we are planning to use ceftazidime avibactam plus Astronom, then you definitely, we have to make sure that the combination is going to work. Again, not something which should be empirically started for Pseudomonas. So these are important things. Your chances of going wrong would be 1% for E. coli Klebsiella, would be around 20 to 30% for Pseudomonas, and almost 100% for Acinetobacter if you're using something like ceftazidime avibactam plus Astronom. So let us end with what does avibactam inhibit? Important. Yes, sir.
Yeah. So in Leelavati, what we are doing is for all the isolates which are enterobacterial, we are looking at, apart from ceftazidime, avibactam plus Astronom, as you said, even if it's OXA48 or OXA plus NDM, unless you demonstrate the susceptibility, you cannot use that. So using that sandwich technique for ceftazidime, avibactam, and combo. Plus we are looking at phospho, and also we're looking at minocycline and trimethoprim sulfamethoxazole. So in our clinical practice, we have seen that even the Klebsiella and E. coli enterobacteriaceae, around 15%, 10 to 15% are susceptible to minocycline, even when the tetracycline MICs are intermediate or less than 2 or 2 at the order. And we have seen around 20 to 25% of the isolates being susceptible to trimethoprim sulfamethoxazole. Of course, in hematology patient, it would be a challenge to use trimethoprim with the bone marrow suppression. But this is something additional what we do for enterobacteriaceae at Leelavati. Rahul?
Yes, absolutely. Thank you so much, sir. I completely agree with you. Again, Mino and TG, so there can be different resistance mechanisms. So there is this TET B versus TET X. So, one doesn't predict resistance for the other. So again, we have to know the avibactam spectrum. What does it inhibit? What does it not inhibit? I will leave my BMT physician for the end. So, Dr. Balar, do you detect BMT colonizations in your clinical practice with rectal swabs, something that Nagwekar sir was talking about? So we'll just take this last question and take his opinion and take Nagwekar sir's opinion, and then move on with the summary.
Yeah. It is our routine practice to send even rectal swab along with the nasopharynx swab for a microbiological culture, and if possible, we'll send the PCR also.
Nagwekar sir, your take on this?
Yeah, so I think, as I said, if the patient is come for the first time directly detected, then possibly I wouldn't send. But subsequently, if the patient is a second admission or had a prior admission, or if the patient is not getting better, I would definitely do the surveillance rectal swab, so that might help you not getting better. And I'll tell you, apart from BMT in global hospital in liver, though I have not been able to publish my data, whatever laziness of mine or lack of time, but for last 5 years, we have been doing rectal swabs of all patients who have been hospitalized for more than 48 hours in other tertiary care centers. And we not only send a rectal swab, we are one step ahead that we keep them in contact isolation, because all these liver patients, they are already colonized with MDR or enterobacteriaceae. So we go one step further and we keep them in contact isolation till the rectal swab is negative for a CRE. So this is which we do in the. I've got a huge data, but I have not been able to publish that.
Right. Fair enough. Yes. So again, rectal swabs can be useful because they can tell you or give you a brief idea of colonization. The problem is, just doing pure phenotypic methods versus genotypic methods for this, and also the concordance rate. So let's say you have someone who is colonized with a gram negative, what is the chance that a post BMT bacteremia would be because of the same organism? So again, for something like VRE, the concordance rate is a little bit higher. But again, you have to build your own experience. And, as Nagwekar sir said, this can provide you with valuable information. You have to know how to use it. So this is not so that we'll treat those rectal swabs. This is for us to know, what kind of bugs they are colonized with. So I think we are almost done with this. We have almost overshot our time. So instead of me summarizing, I'll probably take all my expert panelists to give us one take-home message, especially for our hematology colleagues as far as managing gram-negative infections in hematology patients. I'll start with you, Dr. Sanket. Take-home messages for managing gram-negatives in the hematology setting.
Always do a risk stratification of the patient that you are saying. Always take the hematologist into confidence. What is the anticipated duration of neutropenia? Do a good clinical examination. I think the rectal swab might work for patients who have been multiple admissions. And always take into consideration the the mechanism of resistance that is operating in the CRE group of organisms.
Yes, Dr. Bala.
My early intervention is the key. Don't wait for the lab results and all these things. Start with empirical therapy, because first 2 to 3 hours is important in any case of sepsis. So early intervention is the key.
Dr. Rahul Kamble.
Consider the hospital antibiogram for the empirical therapy and rational use of diagnostic methods like sepsis biofire or gene expert carbapenem detection, and phenotypic methods for the selection of the for the identification of the drug resistant enzymes and thereby the selection of antibiotics.
Yes, so I've kept Dr. Nagwekar sir's comments for the end. So, sir, final thoughts on gram-negative resistance in the hematology setting.
Yeah, so I think I would say please send cultures 2 sets before you start an antibiotic, before you change an antibiotic, or before you add an antibiotic. So every time you do that, you have to justify whatever you're doing. So 2 sets of blood culture is a must. And if you are dealing with a gram-negative, already patient is on BLPL, so there's hardly any difference between a BLPL and meropenem. So if at all it is that, I would please go with the most broadest antibiotic, that is colistin or polymyxin-based therapy. Do not go to fancy newer drugs. I think you will miss the bus. So you hit hard and go with the colistin or polymyxin-based therapy, depending on what is the most likely source, site of infection. As the first line, always think of which bug, which site, and which is the resistance mechanism. And I would say hit hard, and you can always look back after 48 hours whether you're right or wrong. But if you miss the bus, you cannot turn back and see it.
Absolutely. So, I'll just take one question from the chat box. Maybe I'll get Dr. Nagwekar to answer this question. So Dr. Joseph John has asked us, would you bring in colistin or phosphomycin even in the absence of hemodynamic compromise?
And my take-home message is also very clear. Phosphomycin, you have to understand that it is a drug which would work against more than 90-95% for E. coli, 50% for Klebsiella, almost 100% no for Acinetobacter, and Pseudomonas variable and doubtful. So in this setting, when you are not sure whether what is your bug, when you don't know what is a GNB, there's no second thoughts. It would be a polymyxin-based therapy, and I would prefer. So there's no second thoughts on that.
If you look at the Gujarat's perspective, then phosphomycin is working pretty well for Klebsiella currently, Vasant bhai.
Meaning, I said it cannot be 100%. It is 50 to 70%.
Yeah, but it's more than 80% or 90% that IV phosphomycin is. I think we are getting good sensitivities for that, for Klebsiella particularly.
Yeah, I think you can go ahead with that, but I would still colistin would be more than 95%.
No, absolutely agreed with that. But colistin definitely occupies the top spot. But after that, for Klebsiella, IV phosphomycin, I think is working pretty well here in Gujarat.
It is phosphona with Sanket.
For Klebsiella, I'm asking.
Yeah. So you can go for either Ceftazidime-Avibactam, which is a much better drug. If it is OXA48 or if it's OXA48 with NDM, you can go for Ceftazidime-Avibactam with Astrin-M, provided you demonstrate a susceptibility. Phosphona, it causes a lot of hypernatremia, hypokalemia. It causes volume overload and loose motions, and sometimes it can be. So if you have an alternative, I would possibly look for that. But I agree with you, Sanket. Yes, phospho is an excellent drug, and also I've been using a lot in my clinical practice.
Okay, so thank you, thank you so much, everyone, for your insightful comments, and thank you, Dr. Sanket and Nagwekar sir, for the ID perspectives, and Dr. Balar for the hematology perspective, and Dr. Kamble for the microbiological perspective. So as we have the panel here, this is exactly how GNB in hematology patients should be managed. So it's Dr. Balar's patient, and then Dr. Kamble does all the microbiology workup for us, and then he has to pick one out of me, Dr. Sanket, and Dr. Nagwekar to actually take care of the patient. So this is exactly how this situation needs to be managed. This has to be a teamwork. because the kind of advances that we have, it has to be a team effort. We have to get all the information up front. There are various things to think of, what is the resistance mechanism, what is the enzymatic spectrum, what is the kind of drug that we are choosing, what is the dosing strategy that we are choosing. So once again, thank you so much to all our panelists. It was indeed enjoyable. I learned a lot interacting with you. And I think, back to Seema ma'am for the rest of the session.
So thank you all for giving us a really good overview on gram-negative septicemia, because gram-negative septicemia in hematologist practice, whenever we get the gram-negative septicemia, we are really very worried because the mortality is very high. But this session was a really good learning session for all of us. And we have learned a lot that even though we are worried and we want to start empirical, before that we have to take the blood culture, because under the name of gram-negative bugs, there are different bugs. So, and each bug require a different strategy. And for that strategy, definitely microbiologist, micro lab, ID specialist, each one has a very important role in giving a better result. So thank you very much for your input, and they will definitely, all your inputs will be definitely helpful in our day-to-day practice in treating gram-negative septicemia. I'm sorry, I'm not able to take questions because of the time constraint. It's already we are 15 minutes behind. But thank you very much. Thanks a lot for everyone for sparing time, because all of you are having busy practice and having on Sunday sparing more than 45 minutes is really good. I'm really highly obliged and thankful to all of you. Thank you.
Thank you.
Thank you.
Thank you. Thank you.
So we'll now move to our next session, and our next session is on VTE Unplugged. And for that, the moderator is Lieutenant General Dr. Velu Nair. Next. So he's presently Group Head and Chief Consultant, Haemato Oncology BMT, a comprehensive blood and cancer center, Ahmedabad, that is CBCC Ahmedabad. Formerly, he was Director General of Medical Services Army, President, Honorary Surgeon, Dean AFMC Pune and Army College of Medical Science, New Delhi, past President of ISHBT. Presently, he is Chairman of Nuclear Accident Management Committee of APBMT, elected council member of National Academy of Medical Sciences, and he is a chair, co-chair, and member of various committees of ICMR, DBT, DRDO, and NABH. He is a keen researcher with, and he has well published more than 250 publications and authored 3 textbooks of medicine. He is a teacher and examiner of MBBS, MD, DNB, and DM and PhD student. So I invite Lieutenant General Dr. Velu Nair to now conduct next session.
But slide दिखा दे, slide लगा.
On VT, yes, VTE, and specifically we are going to emphasize or focus on the deep vein thrombosis. Over to you, Doctor.
कनेक्ट नहीं हो रहा सर, वहाँ पे शेयर पे क्लिक करके सर हमारा पीपीटी खुला हुआ है सर.
अच्छा, कहाँ पे? Can you see me, Seema?
Yes, very well.
Yeah. So good morning, everybody, and thank you, Dr. Seema, for the kind introduction, and congratulations on hosting the 15th CME without interruptions, even in the COVID era. And we are all delighted to be here. We have an eminent panel of experienced clinicians, and also we have a expert lab person, none other than Dr. Sukesh Nair from Vellore. So can I have the slide with the panelists, please? Can you do the slide sharing?
सर मैं एक मिनट, so sharing आया नहीं था मेरे पास.
Here it is. There is
share.
Yeah. Can you see?
Slide share पे एक बार क्लिक कर दीजिए सर.
Yeah, I've done it. Yeah.
सर उसमें पीपीटी दिख रहा है सर आपको, पीपीटी वाला?
हाँ.
पे क्लिक कर
दिख रहा है.
सर उस पे
क्लिक कर दिया.
पासवर्ड
Okay. Okay. हाँ अभी
सर पीपीटी पे क्लिक किया सर?
कर दिया
सर वो शेयर हो गया होगा सर?
नहीं हुआ यार
उसको स्लाइड शो पे करना होगा.
हाँ can you guys see the slides?
Yes, sir, it is visible. You have to put it on the full screen mode.
Yeah. Okay. So the panelists for today, I hope I'm audible. If I'm not, please tell me, because it's the beginning of the panel discussion. The four panelists are Dr. Abhay Bhave, who is a hematologist of repute and works in Lilavati Hospital, Mumbai, Global Hospital, Mumbai, and Empire Haematology Oncology Center in Mumbai. Followed by this is Brigadier Sanjeevan Sharma. I'm sorry, he's promoted now. It's long time, over 6 months, and he's a consultant Haemato Oncologist and BMT physician, and also the professor and head of Department of Hematology and Medicine at Command Hospital, Lucknow, one of our major hospitals in the armed forces. Then we have Dr. Joseph John, who is a professor and in the Department of Clinical Hematology and BMT at Christian Medical College, Ludhiana. Then we have Professor Sukesh Nair, who actually is from the Department of Immunohematology and the Department of Pathology, CMC Vellore. All these people have been working in this field for decades now, and they bring a lot of experience cumulatively. I think we have a huge amount of experience thrown into this platform. So, since this CME is for the level of postgraduates and in MD Medicine, MD Peds, MD Path, and of course, you will have a lot of other people who are undergoing trainings. We are keeping this panel discussion at the level of postgraduates. And how we're going to do this is, we're going to be asking questions to these panelists, and thereafter, we'll be showing a few standard slides with respect to what they have said, just for the students to recap it. That's it. So we are going to start, I hope all my panelists are on the platform. Is Dr. Sanjeevan there? You're muted. Just unmute yourselves.
Yeah, I am there, sir.
Yeah, very good. And Dr. Joseph John?
Joseph, unmute yourself.
Yes, sir, I'm here.
Yes, let's see your nice face, my dear. And Dr. Sukesh? Professor Sukesh?
Hi, sir.
Yeah, just, unmute, and also, can we have your video on, please?
It's on, sir.
Okay, that's right. You can see the flowing beard. Yeah, that's really great. So can Dr. Abhay Bhave?
Hi.
Hi, nice to see you, Abhay. So all the panelists are on board. So needless to say that venous thromboembolism is the third most common cause of vascular mortality worldwide. And, 2/3 of these episodes are in the form of DVT and 1/3 in the form of PE commonly. And less frequently, you have thrombosis in the upper limbs, mesentery, renal, hepatic, cerebral sinus venosus. All those are uncommon. So we're going to, in the interest of time, restrict ourselves to mainly DVT, because PE itself is a complete session itself. So with this introduction, we will start with the first panelist, that is Dr. Brigadier Sanjeevan Sharma. So Sanjeevan, if you could just tell us basically how do you define VTE and what would be the main risk factors, genetic and acquired, in your view?
Sir, VT conventionally combines any abnormal clotting within the circulation, venous or arterial, but predominantly we are talking of a venous thromboembolism here. So whether in the deep veins or in the superficial veins, any abnormal clotting which leads to symptomatic discomfort for the patient and risks for further embolization into the pulmonary circulation, which could be fatal. The risk factors which could be both acquired as well as genetic. Of course, acquired risk factors are much more germane and common. They could be immobilization, post-surgery, especially surgeries involving the orthopedics, the gynecological or the pelvic surgeries, any indwelling long-term medical devices, consumption of oral contraceptive pills, and the genetic factors. What we have identified, I mean, the science so far has identified, probably represent just about 30% or so. But amongst the big host of risk factors, yes, please, ma'am, anything? Okay, I thought I'd
just mute yourself, Dr. Seema.
So genetic risk factors could be, the commonest is being factor V lead-in mutations, prothrombin gene mutations, or the MTHFR gene mutations. But then there is a whole host of, the anticoagulant proteins like protein C, S, and antithrombin 3 deficiencies, some unverified other congenital risk factors, genetic factors like a homocysteine. So there's no end to them, but predominantly we are looking at acquired factors and certain things which not only by surgery or by other lifestyle things, autoimmune conditions, whether it is the anti-phospholipid syndrome, autoimmune disorders, especially in females, that is SLE or other connective tissue disorders. These are also important risk factors for a venous thromboembolism.
Thank you. And of course, in our era today of high-dose chemotherapy and BMT, central venous catheters.
Yes, sir, that I mentioned in the initial part. Any indwelling devices.
Yeah, indwelling devices, and even air travel, prolonged air travel in risk groups, and also, of course, environmental things like high altitude is utilized as a recreation and also as a vocation. So even that adds to it. And what are the main differentials when you see a patient coming with a swollen unilateral leg? What are the differentials you usually consider? This is mainly for students.
Sir. Yes, exactly. So the first thing is, yes, any sudden, abnormal, acute onset, painful swelling of the unilateral painful swelling, we should be considering DVT, but it is equally important for us to know the differential, because sometimes a Baker cyst or a cellulitis can mimic an acute DVT. And on one hand, while it is important for us to exclude these other differentials, but whenever we are in a doubt that whether it is a DVT or one of these other conditions, we should remember that we should give importance to the diagnosis of DVT, because delaying the treatment of DVT can have disastrous consequences.
Thank you. Thank you.
Yes, I'll just take the part C also, sir. I mean, just in the flow of things. And to confirm, because why I said this, it's very easy to confirm a diagnosis, because compression ultrasound, whether a plain ultrasound, which is very readily available, or in centers where a color Doppler ultrasound is also available, that will confirm the diagnosis of DVT within minutes. But I'm saying it from the point of view that many a times in our peripheral centers, color Doppler flow imaging may not be available, and sometimes even a compression ultrasound may not be available in certain primary health centers. So clinician may have to rely purely on his clinical sense.
Next slide. Okay. Am I audible? Somebody just messaged me that I'm not audible. Am I audible?
Yes, sir, you're audible, sir.
Yes.
Okay, okay. Can I have the next slide, please? So I just have a few slides to show. I think there is some technical problem this morning. I don't know why it's not flowing. So the next slides. Can I have the next slides, please? Next slides.
Sir. तो next पे click करेंगे ना तो आ जाएगा मेरे यहाँ जो नेट का हो रहा है.
Okay, okay. So this is what Sanjeevan said, that basically VTE is DVT plus minus PE. Okay, and then you have, he said, this is the multigenic theory where the genetic and the acquired factors, he's highlighted all of them. But immobilization becomes very important in the era of, especially surgery, obesity, cardiac diseases, and, like COVID era, sick patients who are immobilized for a long time, especially when they are on ventilators and things like that. And who clots, more the risk factors cumulatively, more the chances of a clot occurring or a thrombosis occurring. So obviously, risk stratification is very, very important, which we generally do. And this is the good old workhouse triad, which still holds good. But of course, we throw in the molecular features here. So decreased blood flow, alteration in the blood complements, which causes hypercoagulability, and endothelial injury or dysfunction will all add, but we know a lot of molecular features which play a role, which contribute. It's known to work out so many years ago. It still holds good, but we know molecular features now, how it works. So the pathogenetically and the pathogenesis, pathobiology is better known now. And this has also been told, the inherited factors, as Brigadier Sanjeevan has told, prothrombin gene mutation is not commonly seen in our country, and the acquired features are as shown. And here we must also, we will be talking about malignancy, and we may get time to talk about HIT also, but definitely these are important ones. And the central venous catheter is today a primary source of upper limb and other thrombosis which occurs in our practice, which you must know and we must discuss. And these are the symptoms which he's told us, but the commonest is pain and tenderness. You know, with edema, and you don't generally try to elicit a Homan sign, those been reported, but we don't do it. But swelling and erythema can be involved, and with that, a DD of a ruptured Baker's cyst, cellulitis, injury, trauma should all be elicited, because that's very important. But the diagnosis should be followed up to a conclusion, because like Brigadier Sanjeevan said, treatment is an emergency. So these are the commonest DDs that we talked about. Trauma with hematoma is one of the commonest. Now, the right diagnostic tool, you have a whole lot of them here. Venography is historical now, used to be the gold standard. But your ultrasound, isotope venograms, perfusion scans, MR and CT, and lab D-dimer. And the ultrasonic findings, you must know as a clinician, especially what is the report that you're looking for. One is the visualization of the thrombus, which is anechoic to hypoechoic. And a hyperechoic is when the thrombus becomes organized and old. Compressibility of the vein is lost, and the caliber and the wall thickness also increases. There is absent blood flow. And in a thrombus of standing, new collaterals start developing. Clinically, when you look at these patients, they'll have prominent superficial veins. These are the sensitivity, specificity of the various tests used. As you can see, the good old compression ultrasonography has got excellent sensitivity and specificity in symptomatic patients. It dips by 30% when you go to the asymptomatic patient. Okay, and MRI has got comparable. You see D-dimer, which is so used by so many people and also misused. Symptomatic is very high sensitivity, but here is the problem: specificity. So here, I'm sure Dr. Sukesh will tell us more about this. And the complications which are common, which we will talk about, acute and chronic, and we're going to discuss this, at least some of them. So acute are pulmonary embolism and venous gangrene. Fatal pulmonary embolism is responsible for 10% of hospital deaths. Most often it's not diagnosed. And the chronic complications are chronic pulmonary arterial hypertension and the post-phlebitic syndrome, which is common and it is frightening. It can really impact the quality of life, and see the frequency increases with each year. And at 10 years, is a large number of them who get it. So I've come to D-dimer testing now, and I come to Dr. Sukesh. So Dr. Sukesh, can you just tell us the importance of D-dimer testing, its sensitivity, specificity, and pitfalls?
Yes. So, sir, before that, I would just want to highlight the role of a laboratory in venous thromboembolism.
Sure.
There are mainly four roles. One is to provide ancillary data to help what Dr. Sanjeevan Sharma was mentioning, like D-dimer. Second one is to possibly identify risk factors which could cause, the risk factors that you listed out, because more than 50% of VT are associated with some risk factor. The third, which is of course a myth, which is, can we identify risk factors which can predict recurrent thrombosis or rethrombosis? And the last one is, of course, helping monitoring anticoagulation. So these are the four more important roles of laboratory in venous thromboembolism. Now, I have been conducting a lot of workshops in many parts of the world where testing is not available. And the scenario that Dr. Sanjeevan Sharma mentioned was very rampant. Because D-dimer is a very, very important test, at the time of presentation, I mean, it should be the test that should be offered. But the problem is, it is not done. In India, most of the clinicians who suspect venous thromboembolism don't do D-dimer. And it's not only in India, many parts of Africa, many parts of Asia, except for probably Europe and US. Now, the reason is, I asked them, most of the clinicians says that venous ultrasonography is easily available. VQ scan is easily available. They are more easily available than a quality D-dimer testing. So therefore, the quality of D-dimer testing is very important. I hope that may change after the false target that COVID developed in the form of D-dimer, the magic bullet or the false target. So fortunately, a lot of laboratories are now able to have D-dimer, called good quality D-dimer testing available, because the D-dimer testing has increased to almost 50 times after COVID started, with good quality, in fact, installation of good instrumentation in many laboratories because of D-dimer. So I hope this could change the scenario. But please understand, sir, as you mentioned, D-dimer is a very, very important test. As you showed the sensitivity and specificity, you showed the sensitivity of 99%. There are many D-dimer testing which has got a sensitivity of 100%, which basically means this test has got a good negative predictive value. So if you use a good clinical prediction score, I mean, or a rule like Well score or Geneva score, and you do D-dimer, you can effectively rule out, because 70 to 80% of patients who present to OPD, data has shown that though you suspect venous thromboembolism, they may not have venous thromboembolism, especially in OPD, presenting to outpatients or emergency. So, clinically, clinical acumen is good, but you can have a high risk of misdiagnosing venous thromboembolism and starting a good proportion of patients to a life-threatening drug like anticoagulant. There are risks. I mean, anticoagulant is not life-threatening; it's life-saving. But there can be issues related to anticoagulation when it's not required. So therefore, D-dimer testing is, and especially, literature has very clearly classified D-dimer testing, and there are point of care D-dimer testing, which has got a sensitivity of 100% and negative predictive value of 100%. That is available in the market. So I think choosing the right D-dimer testing is very, very important. And I think it should be done at the time of presentation, because data in the last 5 to 10 years have shown that D-dimer testing at the time of presentation could possibly identify a cohort of patients who come with unprovoked thrombosis or thrombosis in rare places, who may have a higher risk of recurrence. That is, D-dimer levels more than 1,500. They probably benefit from longer anticoagulation than those who have less than 1,500. This is a data that came from Norway. I think it was data that was developed over 20 years. So I think then reproducing that data will take some time, but you cannot do without D-dimer testing, because it is almost helping you to predict which patients will benefit from longer anticoagulation, who may have chance of recurrent thrombosis.
I couldn't agree with you more. So he's emphasized amply the importance of D-dimer test in the context of VT. The other thing is, if you go across to metropolises, sub-metropolises, any DVT occurs, and an average practitioner straight away sends off a panel for thrombophilia testing. So this is abused very often. So I want to put this in context. Which are the subsets where whom to test, what to test, and when to test? Because it's good to tell, because obviously, I want this message to go.
Yes. So whom to test is obviously you have confirmed venous thromboembolism. Yes, they are to test, because we have to test for risk factor. Now, sir, people, the physicians or obstetricians who take care of these patients, they want to, give the best to the patient. So their immediate feel is that, okay, let's identify risk factors. Fortunately, guidelines have come out where we know that you cannot overcome those pre-analytical issues which are associated with thrombophilia testing. Like, you should not take a sample when the event, close to the event, You can, and obviously after the event and you confirm, you start anticoagulation. So you can't take a sample when the patient's on anticoagulation. You can only take the sample after the period of anticoagulation is over, and probably a few more days after that, because anticoagulants will affect protein C, protein S levels, especially the vitamin K antagonists. And then of course, heparin can affect antithrombin levels. Even the thrombotic event itself can affect the levels of these proteins. It can affect APCR. Of course, molecular testing will not be affected. So like factor V laden mutation, prothrombin is not that common in our country. And MTHFR mutation probably is not as important as homocysteine levels, because homocysteine levels are better predictor of risk factor than MTHFR mutation. Of course, that will also have hyperhomocystinemia. So, so what is the guideline has said that if you identify a deficiency, and we know that many of these deficiencies can be brought about by a pre-analytical error, they need to be reconfirmed on a sample that is collected fairly after anticoagulation. So you cannot give a diagnosis of antithrombin deficiency on one result. You cannot give a diagnosis of protein C deficiency on one result, protein S deficiency on one result. You cannot, or APCR on one result. Like it's, even antiphospholipid, they have built in the safety factor of 12 weeks. So I think, fortunately, because that rule exists, I think we are fairly able to overcome some of the most common pre-analytical issues that you had been, emphasizing on. So also to what to test. I mean, we discussed what to test and these type of tests that you need to do, because the thing is nowadays many instruments are able to do a lot of complex procedures very easily. So because they are available, sometimes you may offer an antithrombin test because your machine can do antithrombin antigen. But you must realize that we can't get anywhere close to an antithrombin deficiency with an antithrombin antigen, because it's available in a biochemistry lab. You need to do the activity, because almost 90% of antithrombin deficiencies, that type of test. So selecting the test is also important, and also the place where the test has to be performed. That is also very important. So the thing is, in India, the pre-analytical care is absolutely very poor in coagulation testing, because samples are transported across temperature zones which are not compatible for coagulation testing. So if the testing is not done in your place, in your lab, please, you have to advise the people not to send the sample when it's possible, to make sure that the patient can go to a place where the testing is done. And of course, because these testings are complex, it should be done in a place where there's adequate expertise to interpret the test. Test results are easily possible with instrumentation. But if there is no expertise in interpreting the test with the background information that's available, it is quite risky to get the results on a patient. So that's what I wanted to say, sir.
Thank you so much. I think you couldn't put it better. He's covered all the practical points, and I find that sampling and conveyance of samples in the months of summer in North India and other parts to places where it keeps sitting on the shelf, and then doing a test and then interpreting that as an abnormal thing can be a very big trap. So for the unwary clinician, and you end up actually, just creating so much of anxiety in the whole family. And then you end up with saying, okay, do family screening, and how long should the anticoagulation be? So there are lots of implications of what you get from the lab. It's not just that you get a lab report, it's what you do with the lab report, which is important. So the thrombophilia testing, whom to test?
Abhay has raised hand. Abhay has raised hand.
Okay. Abhay, can you hear me?
Unmute yourself, Abhay.
Yeah.
Yeah, Abhay.
Yeah, I just want to make a statement that irrespective, first of all, hello to everyone. And Seema, thank you very much for inviting us on this discussion. And Velu, thanks for moderating it. The thing is, I'm very clear that if an event of DVT is provoked, I'm not going to do any test upfront.
Great.
If it's unprovoked, I'm not going to do any test upfront. The only test that I'll want to do at that point of time is to see what kind of anticoagulant I'm going to use.
I agree.
Will it be fair that I ask for two specific tests? One, which is an APLA-related test, because I want to know whether to use the DOACs or not. And Sukesh will have to tell me whether the APLA testing, such as LA, ACA, and beta-2, will be affected by a current clot, not the anticoagulant, the current clot. Lupus anticoagulant will be affected by anticoagulant. One, if the clot is at an unusual site, such as in the abdomen, that the splanchnic circulation or in the brain, I might want to prefer to do a JAK2 mutation or a PNH, because here then my etiology may be different and they may be constant provoking factors. So then even if it's a provoked event, it may be a provoking event all lifelong, and therefore my anticoagulation thought process might change. So I don't do any tests. I am not liked in my hospital, but I don't do any tests because doing tests is a lot of money, and I'm against doing it unless these 2 or 3 things which will help me to guide management.
Thank you, Abhay. Actually,
But you'll do D-dimer?
Of course he will do. I'm sure, he was talking about the special test, I suppose.
Sukesh, if there is a obvious thrombus which is there, how is D-dimer going to help me further?
You can identify patients who may have benefit, who may be having, you can identify people who may have possible risk of recurrent thrombosis. At the time of presentation, D-dimer more than 1,500. I think I sent you that paper.
I'm not worried about recurrence at the time of diagnosis.
So let me put this in perspective. The treatment for DVT remains the same, whatever is the risk factor. The treatment immediate is the same. So that's the important part. And here you have to optimize the resources. We are a country where we have both the rich and the poor. So, in a hospital setting, government, the approach is a little different. In private is a little different because you have to spend out of the pocket. So out of the pocket, what Dr. Abhay is saying, obviously, I also in my practice don't do any thrombophilia testing except for some specialized groups or when it's already known that it's a known case of APLA, those are the secondary ones. But in a de novo, so-called, primary thrombosis of idiopathic origin, treatment is the same. So these tests can follow depending on the index of suspicion and the location of thrombosis. And mainly we are talking about DVT here. The other special situation Dr. Abhay said are relevant, definitely. So whom to test for thrombophilia is what I'm saying. So age is 45 to 50 years. Unusual sites, whether it's the CNS, whether it's the abdomen, idiopathic recurrent VT, family history of inherited thrombophilia, warfarin-induced skin necrosis, and whenever recurrent abortions, fetal wastage syndromes. And then these are the tests available, out of which in our country, we do not do any of these. These are all historical. HAM, sucrose lysis are all historical. And we obviously also don't end up doing the prothrombin gene mutation because it's not common in our country. But the others are all available. And depending on the panels available for packages, it is resorted to. And when to test? In acute thrombotic situation, there's no point doing the test. They're all low levels. So you will get false positive results, which is very anxiety generating, and you will waste more money. So don't do these tests upfront. And any abdominal test which you get later on also, what you do in such situations must be reconfirmed. And obviously, like I told you, the treatment remains the same and always takes precedence over investigations. Okay, now we come to, to Dr. Joseph. So Dr. Joseph, in your practice, what is the role of pre-test probability assessment like Wells scores, Khuranas in cancer situations? How do you use it in the medical ICU, surgical ICU, and others?
So thank you for this question and the wonderful discussion which is going on. The discussion on D-dimer actually has set the way.
You're not audible.
For using the pretest probability.
Yes.
If the evaluation of a pretest probability is usually in the medical ICU is by the test called Wells score, Wells criteria, that looks at various parameters of clinical and science, clinical history and science. And I would not go into the details of that because it is cumbersome, cognitively quite challenging to remember all of that and put the scoring in the mind. If you have a app, it is good to know that. But
Here
essentially, what Wells score is prevent.
I'm showing it to you.
Okay, sure. So that's great. So if it can be done, it is great. It has two types of Wells score. One is to predict the probability of DVT, predict the probability of pulmonary embolism.
This is DVT.
Yeah. So the essence of that is whether to do a D-dimer or not to do a D-dimer. Essentially, controlling the over evaluation of D-dimer is a question there. I mean, we heard the arguments to do more and more D-dimer, but this is essentially to tell you
your audio
whether
is
to do more D-dimers or not. And based on, sorry?
Your audio is
to
getting
tell you-
lost in between.
Okay, I'm sorry about that. So basically, depending upon the score, whether it is 0, 1 to 2 or more than 3, the probability of pretest probability is basically a Bayesian way of looking at this as 5%, 17% or more than 17%. Therefore, whether to use the D-dimer or not. I must tell you that this test is not to decide on thromboprophylaxis. This is basically to predict the probability of doing the D-dimer. If the D-dimer is positive, and then we can go ahead and do the confirmatory tests of CUS or D-dimer then. So if you look at it, there are more than 14 scores available in MedCalc regarding thrombosis. Now, it's not practically possible for us to do the scoring and decide. The bottom line is history, a careful history, careful examination, and look for clinical signs, which will predispose to your clinical pretest probability or a laboratory pretest probability of finding a thrombus. That's it. So that's about well score. In a surgical setting, they are looking at a score called Capri score. Again, another scoring to remember, but essentially it is a Capri score which is used in a surgical setting. Then the situation is in a gynae obstetric patients. Again, there are no particular scores as such. They are mentioned in the papers, but again, we would go by similar prior history, their predisposition, essentially the environment, the host, and the agent is what we are looking at and looking for, like Dr. Velu had shown, sir has shown the Virchow's triad, and that is essentially it, what we are looking at and the consequences of that. Corona score is something which is based to predict the risk of thrombus in a patient with cancer, an ambulatory patient, not in a hospitalized patient. So Corona score, the dictum is it has to be an ambulatory patient, and they have not included myeloma in that. Therefore, it is more applicable to lymphoma and other solid tumors. So that's a key there. Again, a risk of predictability. There are some trials going on using that and giving thromboprophylaxis and checking whether that has reduced the incidence of thrombosis. That's the way the well score, the Corona score, the Capri score, and in fact, there is one more called the Padua score in the ICU.
Yes. So, Dr. Joseph,
so these are various the top 4 scores, I would say. Sorry,
I
Padua,
said,
Padua.
Yeah. It's amply put, clearly that you have the scoring system from Wells to Padua to Corona to Capri. Now, a quick question on, shifting from the DVT in the lower limbs to upper limb. Diagnostically, we said we use compression ultrasound as the commonest one when DVT is the commonest form of thrombosis. In upper limb, what makes you suspect thrombosis and what do you use to confirm diagnosis?
Yeah, so 2 ways of developing upper limb thrombosis.
Your voice is being lost, Joseph.
As opposed to the lower limb thrombosis. One is a spontaneous upper limb. I don't know why there must be an internet issue here.
No, Joseph, if you don't mind, if you put off the video, sometimes
yes, I'll do that.
And just be a little away from the laptop. Don't be too close. You're going over the mic.
Okay, so is it possible to hear now?
Yes.
Okay. So upper limb thrombosis, essentially 2 situations. This is thrombosis secondary to an activity or a spontaneous thrombus, or are we dealing with a catheter-related thrombosis?
Yes.
When it comes to a spontaneous thrombosis, it is basically a thoracic outlet syndrome obstruction, which predisposes, and otherwise called as a Paget-Scrotus syndrome, where it is a subclavian compression which is causing thrombosis. Classically, a weightlifter or an active person comes to you with a spontaneous thrombus after an extraneous activity. That's very less. The most common is the catheter-related thrombosis, and we have various predispositions, but the key is to look at it clinically suspect even when the patient is asymptomatic. That is the upper limb edema. There is a differential edema on the limb where there is thrombus and there is pain or swelling. So we need to differentiate between cellulitis, thrombophlebitis, and thrombus. So Doppler would be the option there to confirm that. And the treatment would be depending upon the risk factors, which is ongoing, the necessity of keeping the line there, whether we can give the anticoagulation for 3 months with the line there or remove it and give it for a shorter period and remove that, depending upon the counts of the patient. In a hematological setting, classically, if it is when the patient has thrombocytopenia or no thrombocytopenia, actually then decides whether we want to keep the line or not, the line, and give anticoagulation or not.
Yes, yes. Actually, the decision here is to keep the line or not to keep the line in the background of thrombocytopenia or no thrombocytopenia. So it's responsible for upper limb DVT about less than 5% of all the VTs. And of course, we see it in our situations of high dose chemotherapy and also BMT. The pulmonary embolism rates are a little high here. It's 15 to 30%. And the clinical typical features of DVT may be lacking. If you get the other ones, what Dr. Joseph has said, very good. And obviously, ultrasound is not the modality you can use here. So, venography has a role sometimes here, where you can do the imaging techniques to pick it up, especially when the central catheters are involved in a distal fashion. And the risk factors, he's already told you that, but certain malignancies are more prone for this, and especially in the setting of solid tumors, adenocas, your ALLs, and the older catheters, which are cheaper. The polyvinyl, the PVC catheters were associated more with thrombosis than the silicone ones. And obviously, certain chemotherapeutic agents are more involved, and it may not be related to the inherited thrombophilia risk, which very often we think is the case. And the symptoms are shown here. 30% are asymptomatic. The symptoms are less than 15%. But what's important is the sequelae. If you miss it, they can come with an ugly upper limb swelling as a post-phlebitic syndrome and a life-endangering situation of pulmonary embolism, which I told you. So those are the two things which are important, which have been highlighted by Dr. Joseph. I come to Dr. Abhay now. Dr. Abhay, we coming to you're coming to CAT, cancer-associated thrombosis. So what is the prevalence of such thrombotic events in malignancies, and which type of malignancies are more commonly associated with CAT? Role of thromboprophylaxis, use of Khurana's score, and how long will you anticoagulate these patients, if you can answer these in this order?
Okay, so thank you very much for the question. I think your first question was, what is the prevalence of CAT amongst malignancies? And is there a predisposition for some malignancies to have a higher incidence of CAT? So as compared to the normal population, the chance of developing a venous thromboembolism in cancer patients is about 4 to 7 times higher. So the prevalence is about 15% in cancer patients that they could develop thrombosis. And if they do develop thrombosis, then their outcomes are not as good for various reasons, such as not being able to complete the treatment, developing cytopenias, not able to be getting anticoagulated, therefore higher risk of recurrence of VTE, bleeding episodes while on anticoagulation, preventing treatment of the cancer, bleeding causing issues of morbidity and therefore mortality. That's why probably there is a 6-fold decrease in the survival of patients who have developed a CAT in malignancy as compared to non-malignancy patients. And the prevalence of this CAT, or rather the incidence of the CAT, in various aspects of the patient's life while on treatment, from diagnosis to being hospitalized for therapy or being unwell, to putting a CVC, as we just discussed, to taking a therapy such as platinum-based or other therapies which cause a lot of inflammation, promoting thrombosis, till the time they come into remission, the incidence may actually go even higher than 4 to 7 times. That's why CAT in malignancy is rather bad news for the patient in terms of poorer outcomes. Now, you asked me, I think, about whether we can risk stratify. Was that a question, Velu?
Yeah, I just said that do you use Khurana's risk
Khurana's score, yeah. So in Khurana's score, that's the only validated scoring system whether it's the original or the extended one for patients with malignancy. So most of the articles you see on CAT will use Khorana.
Okay.
The issue is whether you should use 2 or 3. Most of the times the cutoff is 3. But sometimes when you got, say, an OPD patient with a higher risk of 2 or more, then you are tempted to prevent a CAT in them, because we know treating CAT is worse than preventing the CAT. So prevention is better, but prevention has not picked up because the benefits has not been very universal, both from the Cassine and the AVERT trial. But at the end of the day, Khorana score of 2 or 3 is considered to be significant. And a Khorana score is simple to calculate also, and therefore it's easily available. And that could be one thing that could be used.
So are you using it in your, yes or no, in your practice?
Yes.
Yes, good. So obviously to the whole audience, whenever you talk of thromboprophylaxis, it's your duty to make sure there is no contraindication to anticoagulation. That's a given. That's a given, but I'm just reiterating it because we have a heterogeneous audience. But you must rule out any contraindication, any bleeding diathesis, any peptic ulcer, any recent surgery, and things like that, which are standard. Which are the settings where you get more CAT in terms of organ, in terms of site, and in terms of histopath?
Yeah, I think that's a great question. Organ-wise, if you see the ones which are the highest incidence of developing a CAT, pancreatic tumors, brain tumors, or mets to the brain, ovarian. So you can divide into 2: abdominopelvic and thoracic brain. Brain tumors, fortunately not very common, but if it's like, say, breast, which has a low incidence, but mets to the brain, then it changes things. So it's not only about site, it's about the histology that you asked me also. Pelvic tumors tend to metastasize quite often. So in general, I would say in malignancy, every tissue which is malignant has the ability to cause a clot. It's a relative increase or reduction in their ability to cause a clot. Amongst them, you'll have to see what is the histopathology. So apparently the mucin secreting adenocarcinomas or the adenocarcinomas in general, squamous cell carcinomas, tend to have a higher incidence of thrombosis because they secrete more procoagulant material, which interacts and talks to too many cells inside the blood system that can give rise to thrombus.
Okay.
And also the stage, so the stage of the disease, I mean, the more the disease is progressive, it may have started as a limited one, but if it's not responding to therapy and becomes more progressive or metastatic, then the same disease which we thought initially histopathologically was not associated with thrombosis could become more prothrombotic because of the nature of its change.
Okay. So once you have established a diagnosis of thrombosis of CAT, then what is your choice of therapy, especially with respect to heparin, DOACs, VKAs? Just give me a brief answer.
So I look at SPICE, I call it SPICEs, where I look at, what is the site of the disease. I look at what is the platelet count. I look at what is the elevated risk of bleeding. What is the interaction of the drug that I'm going to use with the drug which is going to be used in malignancy. What's the creatinine status? And that would depend upon my choice. So I made a mnemonic called SPICEs, SPICEC, which just helps me to look quickly. Now, I've got 3 choices: heparin, DOACs, and warfarin. Most of us don't use warfarin nowadays because of the issues. But if you've got a valve in the patient, mechanical valve, or there's an APLA syndrome on which the patient had developed a malignancy, or any other reason for which warfarin is the preferred choice, I will continue with warfarin, because just now, about 3 months ago, there was a paper published that really there's not much of difference between warfarin and low molecular weight heparin. In fact, it was also compared with apixaban, and apixaban was the only advantage that it had over warfarin. So actually warfarin is not inferior to LMWH.
Yes.
In this paper which has just published. So we're getting interesting data as we go along. So for those who need warfarin, I'm going to continue warfarin, but I tell them to be strictly between 2 and 3.
Yeah.
Many times, unfortunately, warfarin has drug-drug interaction with the chemotherapy.
Yes.
So I'll have to keep adjusting. DOACs, again, there is a list. You can look at it. Whichever is the drug interaction, we can look at it and see that either we can use the drug or we can avoid it and go either to warfarin or low molecular weight heparin. And of course, my go-to guy is always low molecular weight heparin. It's a great drug to use. Unfortunately, it's parenteral, so it's a problem, and using it for long term will be an issue.
Okay, just want to quickly cover also in surgery, in surgical prophylaxis, just your thoughts on the risk factors, how you decide when you're called to help in thromboprophylaxis, and your anticoagulant of choice.
So surgical patients now, the discussion which we had earlier on D-dimer does not stand because the fact that a surgical event has taken place, D-dimer will be high because it's just a reflection of the healing process post-operatively. So D-dimer is not to be used. We'll have to go clinically, and then I assume, in fact, in my practice, when I'm doing a post-operative round, I look at why I should not give low molecular weight heparin to a hospitalized patient if he's either in the ICU and the ward post-operatively. So I go the other way around. I assume everyone needs it unless they do not need it. And most of the times you'll be surprised to know that they need some kind of thromboprophylaxis. And the therapy of my choice in a hospital, while they are still recuperating, they are probably either intubated or they've got Ryle's tube inside, they've got drains coming out, they've got catheters here and there, a central line. I go to low molecular weight heparin. Enoxaparin is my drug of choice, or dalteparin for that matter. And the prophylactic dose that I use is 40 milligrams of enoxaparin, or I use 5,000 units of dalteparin. And I watch whether there's any bleeding tendencies. I first look for safety, but I don't forget about efficacy.
Yeah. So you know, Dr. Abhay, one of the common things, let's say a normal weight lady undergoes breast surgery for breast CA and breast conservation surgery, that too not a radical one. She's ambulated within hours and she has no other risk factor, but because of the hospital policy and the surgical policy, they have kept her in the ICU for a few hours post-op. In this case, would you start anticoagulation?
I would look at the other comorbidities, hypertension, diabetes, nothing else. Yeah. So if the surgery has gone off well and there is no other reason to put her on anticoagulation, she should not be on anticoagulation. Yeah. Where are you trying to prevent the clot? In the leg?
Yeah.
She's mobile active.
Yeah.
Upper limb, she doesn't have any catheters and all. Anyway, there's no point giving LMWH to catheters because there is a catheter inside to prevent. So you have to look at it differently.
So you know, it's very important, it's very important to give thromboprophylaxis to the needy people, but you must know there's a real risk of bleeding. So when not to use is equally important. Yeah. So you must, that's why these scores also help you to some extent decide that this is not a candidate.
Velu, if I tell you one thing that, if you tomorrow get a anticoagulant, which you give as a one shot, and it takes care of you for the next week or 10 days, I think we'll be all happy. And if the factor 11A inhibitors come into play, already there is one abelacimab.
So you know, Dr. Abhay, we will come back to that in the next CME. Next year's CME, it will be taken up. Don't worry.
I'm just saying prophylaxis can be more and more safe as you go along.
Yes.
And the question will be whom not to give it to rather than whom to give it to.
Yes. So well put. I come back to Dr. Brigadier Sanjeevan. So Sanjeevan, for example, you said you use LMWH as your first, line of therapy unless there is a contraindication of some sort. So, but normally, how long do you anticoagulate these patients when it's an idiopathic, unprovoked, proximal DVT?
Yes. So, firstly, your first question itself is very, very important. That what should be the choice of anticoagulation? Now, of course, if we have to put the patient on a vitamin K antagonist, then upfront we have to start LMWH and overlap it with vitamin K antagonist. Now the ACCP guidelines are very clear. If the patient is able to take orally, vitamin K antagonist and LMWH should be started simultaneously. It is not that we start LMWH first alone and then add vitamin K antagonist later. It is just for the first 5 days, both will continue. Because within the 5 days, our INR may have optimized, and then we can stop the LMWH and the vitamin K antagonist alone. But the LMWH will continue till the INR is optimized to our therapeutic levels of 2 to 3. So sometimes the LMWH may go on for 5 days, instead of 5 days to 7, 8, or even 9 days till we are able to get. However, if our choice of initial anticoagulation is DOACs, out of the 4 commonly used DOACs, the apixaban and rivaroxaban do not require any LMWH overlap. They can just be started directly. Whereas the other DOACs, that is the dabigatran and apixaban, they will also require an overlap with the LMWH for the initial management. Now, asking what is the choice? So if one goes strictly by the guidelines, now ACCP initially in 2012, that was the last
You can just give the
formal
latest
guidelines which they had.
recommendation. Yeah, just give the
Yeah,
latest.
the 89, but they have updated those recommendations in 2016, and as recent as 2021, they are now saying that in the specific question, sir, which you had put, unprovoked proximal DVT, they are saying DOACs if available, and in our country we should use the word and affordable, then DOACs take a precedence over the combo of LMWH plus VKAs for various issues, not only their safety profile, their non-inferiorities to vitamin K antagonists, but compliance, because ultimately if the patient is not complying and we land up with a complication of DVT, then there's no fun. Just having on a clinical trial that DOACs are as good as warfarin.
So can I just interject here? So what are the red flags when you're using DOACs in terms of creatinine, in terms of
creatinine?
weight?
Yes, that's the only thing. So I think Dr. Abhay Bhave's mnemonic, although he was using it only in context of cancer associated this thing, but I think it's very practical to have this platelet counts, creatinine the value, other concomitant medications going on. So whether the drug interactions will, so if the creatinine is high, then that's the only thing, because most of these DOACs have a renal way of excretion. And in a setting of a renal failure, then of course DOACs will not come. Whereas vitamin K antagonists are extremely completely safe, as is the LMWH. So that's a bit a caveat.
And how long
quickly coming to the second part B, sir, duration. Now, 3 months is the standard anticoagulation period, which has been recommended by ACCP. At the end of 3 months, we have to decide by which time whether is he a candidate for extended anticoagulation or not. Now, for most of the times in proximal unprovoked DVT, and by which time we may have to go for an extended anticoagulation with the risk.
We'll come to that. We'll come to that later.
Yeah, and part C is, but 3 months is the immediate management.
And how early
will you ambulate? So in my practice, I ambulate almost within the first 24 hours. I mean, there is no, if the patient, as long as he's pain-free, yeah, that's more important. We cannot also ambulate if the person is, but if the patient can ambulate, then we should definitely encourage ambulation once the anticoagulation has been started. That's more important.
So the message is anticoagulate, early ambulate.
Early ambulate. And non-pharmacological measures are mainly for prevention, thromboprophylaxis.
We are coming to that later. You can leave that now. You can leave that now. We'll come to that later.
We are going behind the schedule. So can we?
And what you call Seema, we started only at 11:45. We started 18 minutes late. So just want to cover that period because we started that time. Yeah. So I'll just try to finish this. Anyway, this is the 4 cornerstones. Prevent the thrombosis. If it occurs, prevent its extension, prevent the acute complications, and try to prevent the post-thrombotic syndrome. So what is a post-phlebitic syndrome? I'm coming to Dr. Joseph John. Just give me very shortly, what is a post-phlebitic syndrome and how can you best prevent it? Just try to be brief in the interest of time.
Yeah, so post-phlebitic syndrome is something which happens after the thrombosis, as the name speaks, especially if it is not managed adequately with anticoagulation or thrombolysis. And the risk factors are essentially if there is a high venous pressure and there is a backflow when the valves are damaged, and that happens because of lack of management there.
Yes. And what are the risk factors?
Adequate management of anticoagulation. Risk factors are basically a high, extensive thrombosis of the patient. Risk factor essentially is an extensive thrombosis, obesity, and not adequately anticoagulated. And the back pressure changes, and that back pressure leads to leakage of the proteins and fluid into the blood, into the tissues, and cause ulceration there.
Thank you. Thank you. And since we do see recurrence in DVTs, so can you just say, if you highlight what are the risk factors for recurrent DVTs and what are the preventive strategies there?
So the commonest cause of recurrent DVT is essentially if the patient has a unprovoked DVT and or a persistent risk factor. These are the two reasons for recurrence of DVT, and inadequate anticoagulation while on azithromycin. And many studies have shown that less than 60-70% of the patients are actually on anticoagulation, which is a correct INR.
Thank you. Thank you. So for recurrent DVT, this is an algorithm which is followed. And as a matter of fact, while on any of these anticoagulants, if you have a recurrence, you can do a switch if there's no contraindication and no drug interaction which you are concerned with. And along with that, you obviously need to monitor. And like Dr. Sukesh had said, we use the lab and the imaging techniques to pick up the recurrence and treat it actively and to see how long-term anticoagulation may benefit in these patients. And the post-phlebitic syndrome impacts the quality of life. And that's most important is the role of anticoagulant therapy, inadequate anticoagulation therapy. And that actually has got a direct impact on this. And it can be horrendous. These are our actual patients that we are treating. And some of them go to this extent. So they can't wear shoes, they can't wear socks, they can't go for social gatherings. So some of them have suicidal attempts. So post-phlebitic syndrome is not a theory. In practice, it impacts the quality of life very badly. And this is how they come. Okay, then we come down to, I think, the last part is COVID. And because all of us have talked about COVID, thrombosis, vaccination thrombosis. So I come back to, Dr.
Abhay has left. He has another meeting.
Okay, so Joseph, your thoughts on COVID infection and thrombosis and vaccination and thrombosis. That is the VITT, vaccination-induced thrombosis and thrombocytopenia.
Yeah, so some of the diagnostic part there is to actually to look at after the thrombosis, somewhere between 5 to 30 days.
Yeah.
28 days is what they have mentioned. If the patient develops thrombocytopenia during that period with swelling of the legs, these are the two reasons you can look at and say if there is fever as well. Where the platelets come down, there is swelling, that is when you suspect VITT. Now, COVID infections and thrombosis, let me not get into that. That's a huge
No, vaccination. Let's talk about vaccination.
Yeah, vaccination. So post-vaccine, if the patient develops, these two symptoms are when you are supposed to suspect it. Now, to check the antibody to the platelet factor 4 is not really feasible most of the time. And that is a HITT. And some of them can develop MAHA as well. So these are two possibilities we must entertain when the platelets come down. One is HIT and one is MAHA.
So I would add that whenever a patient goes for vaccination, when they consult us, there is a subset who are already on anticoagulants. Whether it's for atrial fibrillation, it's for other indications, he or she's on long-term anticoagulation. So obviously, at the time of the injection, we make sure that its pressure is given, or, you have a 12 hours or 24 hours gap, but definitely don't want a hematoma at the site of injection. Use a 25 gauge needle so that you have minimal chances pressure at the local site. Yes. Now, after that, thrombocytopenia and a rising D-dimer is very important to pick up these patients because it's more in females, it's more in young people, and it's more in the adeno-carrying vaccines like our Covishield and the Oxford vaccine. It's occurred in a lesser frequency in the mRNAs in your Johnson & Johnson, but it's occurred there also. But the frequency is much more in the adeno, Oxford and Covishield, and most of the reports come from this particular usage. And in these cases, obviously, once you develop the thrombosis, how will you treat it? Because you've established the thrombosis by a high D-dimer, and even imaging has shown a thrombosis. And the thrombosis may not be the ideal sites. It may be at the unusual sites in the cerebral venous thymuses, in the abdomen, and can be in the DVT in the lower limbs also. So it can be in unusual sites and in typical sites. So you must have a high index of suspicion because they don't do well if you don't pick it up. Because the morbidity mortality is high, and it's in young females are more outnumber the males, And since these young people come to you, take it seriously, pick up the diagnosis, and in treatment, since the pathogenesis is like HIT, try to avoid, heparin-like anticoagulation, use the non-heparin-like fondaparinux, you have a whole gamut of anticoagulant that we talked about. So you must treat them properly. And that's very, very important, because if you don't, fatality is well known and morbidity is well known. So your comments on the treatment part, Joseph, and I will also ask Sanjeevan and even Sukesh on the lab part on COVID vaccination-related thrombosis.
Yeah, so this is a very tough area, and that's a space which I have limited understanding, limited experience there. So I would say I would use fondaparinux as the choice of agent there, and because of among the choices we have, DOACs may be a solution, but I would want to hear from Dr. Sukesh and Dr. Sanjeevan what their comments on DOACs at that particular point.
Yeah, Brigadier Sanjeevan.
Sir, we've had just about 2 cases here. So we did have to review literature at our center about vaccine-induced thrombosis, thrombocytopenia and thrombosis. In fact, one of them almost developed a venous ulcer. So as Dr. Joseph said, that because fondaparinux just makes sense, because there is an ongoing thrombocytopenia associated, and
so your choice is recommendation is fondaparinux.
Fondaparinux, but it's an evolving field.
Okay. Sukesh, any comments on the lab utilities in the pickups?
Of VITT is not a very easy diagnosis, because there are a lot of HIT tests available in the market. Some of them based on gel beads, which are not very good for picking up VITT. We need to pick up ELISA-based HIT test, either Roche or from Hyphen Biomed. There are HIT tests available on the CLIA platforms, which will never pick up the VITT antibodies. So, you have to find out centers which do the ELISA-based test for the HIT, the PF4 antibodies. I think right now in our country, about 3 centers are offering the test for that, for confirmation. But I think ultimately it's a clinical decision that is very important.
Yeah. Thank you. Thank you so much. So if there are any questions, Dr. Seema, the panelist questions are finished. Is there any question from the audience?
So no, right now there are, because you have given an extensive overview. I think there are no questions right now, but I am really thankful to Lieutenant General Dr. Velu Nair and all the eminent panelists for giving elaborative overview on VTE. And as we all know that VTE is a silent killer. So only 20% patient will be seen, will come to hospital with DVT, otherwise 80%, you should have a high index of suspicion. And with this panel discussion, based on this, many delegates must have got the good learning session on how to pick up, investigate and treat this patient and prevent the mortality and morbidity related.
Panel ko beech mein karo. Okay, thank you. I would like to thank all the panelists who have really contributed actively to this panel discussion on a very important subject, which is still evolving, because we've got newer and newer agents which we never had before. And I think we have covered whatever we can in this limited span of time. I once again like to thank Dr. Seema and the entire team for having given us this opportunity. And the delegates, I'm sorry, there are some questions I see in the chat box, but you can send it by email, we'll answer it, because I think they've run out of time. Thank you very much, and wish you all the best for the remaining part of the conference. God bless. Thank you.
Thank you.
Jai Hind.
Thank you so much. Thanks. So now we move on to next session. Chintan. So before we go on to our exciting session on quiz, now this is a time when we have reached to the fag end of the academic event. And before starting quiz, I would like to express my gratitude to all distinguished and knowledgeable faculty members on day 1 as well as day 2, all delegates, which included seniors, colleagues, medical students from different college, for turning this effort into most popular and successful event. I'm also thankful to Trizone team and Naukar event management team for their creditable back-end support. And special thanks to Kintan, Kavita, Akhil and Megha, who were willing to do any work at any time, and they supported to make this happen, and they really helped me a lot to bring up this event successfully. And last but not least important is support from the pharma company for educational grant, and I am grateful to all of them, especially Novartis, Intas, Zydus Cadila, DRL, Adley, Gufic, and Reliance Life Science. So now we will move on to a next session, and that is a quiz. And for that, I will invite Quiz Master, Dr. Amit Kintan.
Yes, ma'am.
Put Kintan. Kintan.
Yes, ma'am. Yes, ma'am.
Put slide.
So.
Put slide of Amit.
Yeah. Just sharing.
Share.
It has just gone out of this.
So here is Dr. Amit Khurana, who he's my friend and practicing in Surat. And he is very fond of doing a quiz. And in fact, we have a Gujarat Hematology group where every day he put one question of quiz, and we enjoy a lot. And he is I think he loves doing that, and that is why I have invited him. I requested him to do this session for hematology update, and this I think in last 15 years I have done this only once, 3-4 years back, but after that somehow we were not having this session, and now with this quiz master with us, I think in following years also we will be doing quiz in subsequent years also. So to all of you who don't know Amit Khurana, he's a hematologist and Haemato Oncologist, bone marrow transplant physician from Surat. He was trained in NRS Medical College, Kolkata in 2014. After that, he pursued fellowship in clinical hematology from Topiwala National Medical College and Nair Charitable Hospital, Mumbai in 2016, and from Singapore General Hospital, Singapore in 2017. And after that, he has settled in Surat and in practice at Akanksha Hematology Center, Surat. Over to you, Dr. Amit. And with him, there is Dr. Arpan Mehta also, who is he is also a good friend of mine, and he is very enthusiastic and always keen to learn even clinical things. He is a hematologist, but he has a keen interest in clinical work also. He has so much of interest in clinical things that he was with me for at least 3 to 6 months to see the patient. Just out of interest, he wanted to see patient, how they are doing. And all these things, I think he is applying in his pathology practice also. So he is a postdoctoral fellow from Laboratory Hematology, TMC, Kolkata. Then he has done fellowship from Laboratory Hematology, CMC, Vellore, and then fellowship from Molecular Haemato Oncology, TMH. And at present, he is working as a consultant laboratory hematologist and molecular hemato-oncologist at Newburgh Center, Genomic Medicine, Ahmedabad. So over to you, both of you, Amit and Arpan.
Thank you so much, madam, for that warm welcome and giving me the opportunity to conduct the quiz on this wonderful platform. So we'll start with the quiz. We have got 9 teams. The first will be the elimination round of 30 questions. This will be just MCQ questions, 30 questions. After the 30 questions are over, we will select the first 5 teams. And these first 5 teams will go for the grand finale round. This grand finale round will have 6 rounds, and each round will have 10 questions. So total of 60 questions. So let's start. We have got
Amit,
yeah.
Just quickly, the chat box doesn't show only to you the answers. It says host and panelist.
Yes. I know. I will just brief you after that. We have made some changes, and what I will do is you have to just pass me the answers on my WhatsApp. I will tell you that.
That is in second round, na?
That is in the second round. Yeah, that is in the second round. We will just start with the elimination round first.
So everybody has another mobile in hand.
Let me introduce the teams. Just a minute, hold on, please. So we have team A, that's from TNM Medical College, Nayar Hospital, Mumbai. Dr. Amul Khawane, Dr. Suparna Chatterjee, and Dr. Prashant Kumar. Then we have got team B from TNMCH Mumbai, Nayar Hospital. We have Dr. Saloni Kalappa and Dr. Somaya Vagu, sorry. Just a minute, hold on. Sorry for the inconvenience. Team B, we have Topiwala National Medical College, Mumbai, Dr. Saloni Mantri, Dr. Kalappa, and Dr. Somaya Vagu. Team C is KMC Mangalore, Dr. Prachi Gupta, Dr. Maitri P, and Dr. Somaya Bridge. Team D, again KMC Mangalore, Dr. Somaya Gupta, Dr. Sanidhi K, and Dr. Gauri. Team E is from Vedanta Hospital Private Labs, Ahmedabad, Dr. Deepa Trivedi, Dr. Parival Sharda, and Dr. Nitin Rathod. Team F is Smimar Surat, Dr. Nidhi Gajera, Dr. Shreya Sukhadia, and Dr. Kinjal Patel. Team G is again GMC Surat, Dr. Vishaka Gupta, Dr. Ajay Tilala, and Dr. Riddham Sukhadia. Team H is again GMC Surat, Dr. Sonal Kanani, Dr. Ruchita Sangani, and Dr. Kirti Moradia. And team I, that is the 9th team from NRS Medical College, Kolkata, Dr. Bilal, Dr. Rishu Vidatri, and Dr. Abhishek Kumar. So we'll have the first elimination round, and this round will be based on Kahoot.it. This is an app which I think all the teams are familiar since yesterday. I request the event manager, Kintan, to please start with the first elimination round.
The game
Where is the pin? Hold on. Where is the pin for Kahoot? Okay, 619.
all teams is fine. Now I'm locking. So we are starting with Amit sir. Let us start with the first question. This is the score after first round. Question 2. last question.
So
Yes.
it's A, I, B, D, and H. Am I correct?
Yes,
First five?
these are the 5 teams who has made it to.
Okay, so congratulations to the winners. So we have these 5 teams now: Team A, Team I, Team B, Team D, and Team H. What I will do is I will change the team names now. Just please note the teams who are selected. Team A, once again I repeat, Team A, Team I, Team B, Team D, and Team H. Okay, so Team A will remain as it is, Team A. Just a minute.
Also confirm the names also.
Yes, madam.
Sir, Amit sir.
Yeah.
What I'll do is I am demoting rest of the teams as a attendee, and then you change the name, so there will not be any issue.
Yeah.
So I'm demoting team C, E, F, G. These 4 teams I am demoting, right?
Okay. So Team A, I will just write down just 2 minutes. Just give me a break, 5 minutes.
Is there.
So Team A will remain as it is. Team I will become Team B now.
एक second, sir. Sir, Team B is also there. Let it be.
नहीं मैं अभी मैं change कर रहा हूँ सर. एक मिनट, just a minute, hold on. Team A is becomes as it is Team A. Team I will become Team B now. Team B will become Team C. Team D will become Team D as it is, and Team H will become Team E. I repeat, Team A, that is TNMC Mumbai, remains as it is Team A. Team I, which was
Kolkata.
NRS Medical College Kolkata, becomes Team B now. They have become Team B now. Then the third, which was Team B, that is again TNMC Mumbai, becomes Team C now. Team D, which is KMC Mangalore, remains as it is Team D, KMC Mangalore. And Team H, which was GMC Surat, becomes Team E now. I repeat, Team A as it is Team A. Team I will become Team B now. Team B will become Team C. Team D remains as it is Team D. And Team H will become Team E. Has all the teams noted this?
I have noted. So who is renaming?
I am renaming, sir.
Okay.
Yeah.
So Team A is as it is. Which team is remaining still? Team G. I have to demote as attendee. Okay. So Team H will become Team E.
Team H will become Team E.
Team B will become Team C.
Team B will become Team C.
C. Team D will remain as it is. Team I will become Team B.
Team I will become Team B, B for Bombay.
So it is renamed. They can unmute and confirm that we have made a correct changes.
Yeah.
So Team A is
now
from
Team A, please introduce yourself. Team A, TNMC Mumbai.
You need
Please
to unmute.
Unmute and please introduce yourself. Can you please unmute yourself? Yeah. Yes.
Yes, sir. Dr. Amol Khone, Dr. Prashant Kumar, and Dr. Suparna.
Great. Congratulations.
Third one. Where is the third person?
Thank
Third
We
person.
should check together.
Yes, sir.
Where is the third person? We
He
are
is
not.
coming.
Yeah.
He went to the washroom. He will come, sir. 2 minutes.
Okay. Team I was now Team B now. So Team B.
Yes, sir.
Medical College, Kolkata. Please unmute yourself and introduce yourself.
Yeah, so I'm Dr. Bilal, second year PTT of DM Clinical Haematology.
Yeah.
So I'm Dr. Rishu, second year PDT from NRS Medical College.
So I am Dr. Abhishek Kumar, first year PDT from NRS Medical College, Kolkata.
Great. So now we have Team C. Team C is again TNMC Mumbai.
Hello.
Yeah. Team C.
Yes.
So please introduce yourself. Just
You need to switch on your video also.
And
Hello.
yes, yes.
I'm Dr. Sumaya, third year MD Medicine resident.
I'm Dr. Kalapa, third year MD Medicine resident.
Dr. Saloni, pathology resident third year.
Wow. Welcome. Congratulations. Next we have Team D as it is. So Team D from KMC Mangalore. Please unmute yourself and introduce yourself. Team D, KMC Mangalore. Please unmute yourself and introduce yourself. Team D. Yes, Team D, please unmute. Your video is not showing.
Sorry for the inconvenience. Are we audible, sir?
You are audible, plus please, your video is not been shown.
Yes, sir. There is some setting problem. We are trying. By that time, good afternoon, everyone. I'm Dr. Soumya Gupta from KMC Mangalore, second year pathology postgraduate.
Okay. Then next one, please. Another one. Yeah. Now we can see you all. Yeah. Please introduce yourself individually.
Sir, I'm Dr. Sanidhi Kotian, second year pathology PG from KMC Mangalore. I'm Dr. Gauri. I'm second year.
Okay. Welcome and congratulations for winning the round.
I would just like to interrupt for a second or so. Team D, can you please figure out there is some issue? You are not audible well, because that might create problems later on in the quiz. So if you can, by this time of introduction, if you can just adjust your settings, or you can just please figure it out, because in case if you are not audible, then it would be difficult for you. Thanks.
Next is Team E. Team E is from GMC Surat.
I'm Dr. Sonal Kanani, second year resident from Government Medical College, Surat.
You have joined as attendee also. You need to mute that mobile, otherwise voice will be echoing.
Okay, sir. I'm Sonal Kanani, second year resident, Government Medical College, Surat.
Myself, Dr. Kirti Moralia. I am from pathology department, second year resident.
Myself, Dr. Ruchita Sanghani. I'm second year resident at GMC Surat at Department of Pathology.
Welcome. Okay, so we will start with the grand finale round. Yeah.
So we wish that all the teams should switch on their video. They just mute and unmute at the time of giving answer, but video should be on for entire session.
Yeah, video should be on. Okay, are all the teams ready now? Okay, I will share my screen now. Just a minute.
Team E, please switch on your video. Thanks.
Are you able to see my screen? Yeah, are you able to see my screen?
Yes, sir.
Okay, I will do in a PPT mode. Is it okay? Are you able to see all the teams? Is it clear?
Yes, sir.
Okay, great.
Yes, sir. Yes, sir.
Yes,
So
sir.
we'll
It's
go
visible.
with the grand finale round now. As I already discussed yesterday, there are some changes. I will tell you what are the changes made. I will go with the rules before each round. Round 1 is the warm-up round. This is the basic science round. Round 2 is Pehchan Kaun, who am I? Round 3 is Be Mr. Sherlock, lab round. Round 4 is Be Positive, transfusion medicine. Round 5 is It's Not Malignant, benign hematology. And round 6 is Malignant Haemato Oncology round. So teams, we already had a quick introduction of yours, so I will not repeat that. We have team A, team B, team C, team D, and team E. Just know the basic rules of the quiz. Again, important instructions. All the teams should log in with a single computer or laptop. The video or camera of the Zoom should be kept on throughout the quiz. All the 3 participants in each team should be clearly seen in the video. Only the team to which the question is directed should unmute. Rest all the teams should keep mic on mute mode. Rounds 1, 2, 4, and 5. After the quiz master, that is myself, will read the question. I will say your time starts now. You will get 20 seconds after that to answer. Only the first answer will be accepted. Speak out loud and clear. My decision will be final and binding. Round number 3 and 6, I've made some changes. There is some problem in the technical error. You got my mobile number, right? All the teams? Do you have my mobile number? Yes.
One by one, you can say yes.
Yes.
Okay. What you need to do, there is some problem. We are not able to pass on here. So in this passing round, the correct answer you will have to WhatsApp me. Please WhatsApp your correct answer to me on my WhatsApp number. You all have my WhatsApp mobile number. Okay. So you have to give your correct answer to my WhatsApp number.
Can you please send your number? Please send your number, sir.
I will send in the quiz participation one. Okay. I will send hi to you. Once again. Quiz participation is वही वाला number.
Doctor ratio team.
Quiz participation WhatsApp group में मैंने hi भेजा है, but you have to send me on my personally, privately. You have to send me the answer, not in the quiz participation group. Okay. Yes, you have to send me personally. Please do not send in the quiz participation WhatsApp group. Your answer will not be counted. Okay. So write the question number before the answer. After the question is read, 30 seconds will be given for you to type and send the answers. The direct team will answer after the 30 seconds. So one KBC music will be on, and once the KBC music stops, after 30 seconds, the direct team will answer first. Do not answer early. Whatever you utter may give a clue to the other teams. You have to answer within 10 seconds thereafter, after the music stops. If the direct team is not able to answer or gets it wrong, the points will be passed to the remaining team. And if they are right, they'll be awarded the marks. Am I clear with this? Are you clear, all of you? So I have got the WhatsApp messages from team C, team B. Just give me all the messages. Yeah, team D.
Just send hi to Dr. Amit, all teams. So
just write your team name first. Please write your team name. Team A, Amul Khawane. Team E, Sonal Kahani. Team D, Sanidhi K. Team C, Dr. Kalappa. And team B is Dr. Rishu Vidatri. Okay. So I will receive the answers only on this, but I will see if the direct team is not able to answer. This is only for the passing rounds, round 3 and round 6. Okay. So we'll start with the first round. This is a warm-up basic science round. Okay.
I would just like to interrupt. I'm so sorry. I am not able to see all the 3 candidates from each of the teams. So please adjust yourself before the quiz starts. Thank you.
Team C is having some question. They have raised the hands.
Yeah, please do so before we start.
Team C, are you having some question?
Any doubt? Because I'm not able to see
No
them.
question. No question. It was a mistake.
Okay. Okay. So should we start, Dr. Arpan? Is it okay?
Yes, I'm fine. Thanks.
Fine, right? Okay. So we'll go with the warm-up basic science round. That is round 1. Again, the rules. Correct answer is 20 points. Wrong answer is -5 points. There is no passing. 2 back-to-back questions will be directed to each team. Okay. Fine. Other teams on mute mode. Only the teams who are asked question will answer. So first we'll go with team A. Team A, are you ready? Team A, are you ready?
Yes, sir.
Okay, great.
Yes, sir.
Yeah. Identify the molecule. Your time starts now.
Yes, sir. Should we say answer?
Yeah. If you are able to answer, you can go. Please go ahead. Please go ahead. If you know
Jack 2.
Jack 2?
Jack 2,
great.
sir.
Your
Yes, sir.
answer is correct. So 20 points. 20 points to team A. Okay. Next question. Again to team A. Again, you have to identify the molecule.
Rank L.
Sir.
Yes.
Hello.
Yeah.
Rank L.
Rank L.
Rank ligand. Rank L.
No, I am afraid the answer is wrong. It is CXCR4. So -5 points to you. Okay. Yeah. So next is for team B. Team B, are you ready?
Yes, sir.
Great.
Yes, sir.
We'll start with your question first.
I think all 3 faces are not visible. Huh?
Identify the molecule. There are 2 molecules which are shown here and here. You have to identify both of them.
VWF, sir.
Yes. Please be
Von
loud.
Willebrand factor.
You are
Von Willebrand factor.
VWF? No, I'm afraid your answer is wrong. -5 points to you. It is alpha granule containing PF4, and what we are seeing is heparin platelet factor 4 complex conformational change. This is a HIT syndrome. What we're discussing about. Okay, no, never mind. We'll go with the next one. Again, you have to identify the molecule shown by the arrow. Your time starts now.
Hemophiltrin.
डाइमिथाइल
वो डिब्बो हीम आयरन के लिए होते हैं, नॉन हीम आयरन।
डीएमएल
Okay, your time is up. Do you want to answer this one? Yes.
Can we pass? We don't have the answer, sir.
Okay, you don't know the answer. Okay, so no points to you. Okay, the answer is DMT1. Okay, never mind. So no points for this answer to you. Okay. Next will be Team C. Team C, are you ready? All others team to please mute.
Yes,
Team C, are you ready?
yes, sir.
Great, great. Okay, so question to you. Identify the disease. The time starts now.
Yes. Sorry, PNH.
Wait. So you are correct. 20 points to Team C. Next question to you. Identify what is the starting point over here. What is the progenitor cell over here? Your time starts now. What cell are we talking about here? Okay, your time is up. So do you want to answer?
No.
Okay, so no points to them. It is BFU. Okay.
Amit sir.
Yeah.
This is Kintan. This is Kintan, Amit sir. You need to keep that timer little near to your mic.
Yeah. Okay. Fine. I will do it. Okay. Next one is Team D. Team D, are you ready?
Yes.
Team D, are you ready? Okay, great. So question is here. Identify this zone of the lymph node.
Sir, the one which is marked with the arrow on the right. Blue color arrow. The germinal center.
Yes.
Sir, germinal center, paracortical region.
Germinal center? Okay, I'm afraid the answer is wrong. Okay, so minus 5 points. The answer is mental zone. Okay, so next one, nothing to worry about. We have got the next question. Identify any two mutations involved in this pathway. The pathway has been shown: maturation, polarization, docking, priming, fusion. This is the pathway for clinical HLH. So identify any two mutations involved in this pathway. The time starts now. So time is up. Do you want to answer?
No, sir.
No. Okay. So no points to them. So you can see so many mutations are involved. Most common ones being MUNC, syntaxin, list gene mutation. This is responsible for hereditary HLH. Okay. So next we have Team E. Team E, are you ready?
Yes, sir. Yes, sir.
Great. Your questions are over here. Ponatinib, you can see over here, ponatinib, it acts on which mutation? You just have to name the mutation on which the ponatinib acts. Very clinically significant mutation on which ponatinib acts. Okay, your time is up. Would you want to answer? Okay, no answer. So 0 points for this question. Okay, so the answer is T315I mutation. Okay, so nothing to worry. We have got so many rounds. You can score up well after that. Identify the signal pathway shown over here. You have to just identify which signal pathway is over here. Your time starts now. Okay, time is up. So do you want to answer this?
Yes.
No? Okay, so 0 points for this again. So the answer is this is a notch pathway, not signaling pathway. Okay, fine. So we have finished the round 1. Okay, so we'll go with the next one now. That will be Pehchan Kaun round. Okay, this is round number 2. Again, it's not a passing round. Correct answer, 20 points. Wrong answer, -5 points. No passing, 2 rounds of question directed to each team. Okay, so we'll start with this round now.
Can we have a score?
Madam,
Can
after
we
2
have a
rounds,
score?
we are
Can
keeping
we have a score of round 1?
Okay,
Yeah.
I just quickly give. So team A is on 15 points, team B is on -5, team C is on 20 points, team D is on -5, and team E is yet to score.
Okay.
Okay. So Pehchan Kaun round, this is round 2. Again, it's not a passing round. Correct answer will give you 20 points. Wrong answer will give you -5 points. 2 rounds of question directed to each team. Okay. So first is team B. Team B, are you ready?
Yes, sir.
Yes.
Great. Okay. Who am I? 1979 was my annus mirabilis. 3 independent groups discovered me in the same year. I am involved in 60% of